All right. Assalamu alaikum, everyone. Eid Mubarak, كل عام وانتم بخير. Neuropharmacology. Let's begin. طيب. So today we will be covering 7 lectures of your pharmacology lectures in neuro, and they are anesthetics, opioids, drugs for migraines, sedatives and hypnotics, anti-epileptics, and the drugs for Parkinson's and Alzheimer's. Now, in pharmacology, it's important that you obviously understand the mechanism of action, pharmacokinetics, adverse effects, indications, blah, 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 for the drugs. And the way I would approach and structure this PAL is, first of all, I have these abbreviations of these things. But most importantly, this is my approach to pharmacology. Every time I take a pharma lecture, this is how I deconstruct it. Starting with the names of the drugs. Before anything, I must memorize the drug names. And I should never mix them up because sometimes drugs sound the same, but they're very different. For example, there's a antipsychotic clozapine, and then there's clonazepam, which is a benzodiazepine. They kind of sound the same, but they're completely different. And once you understand the namings of the drugs, khalas, you'll never get them mixed up. But memorize the drug names, whether it's mnemonics, brute force, or Anki, whatever works for you works. For me, I do Anki and brute memorization. I have one mnemonic in all this pad. I'm sorry, I'm not a mnemonics person, but I tried. And then you will build this map of drug classes and their important features from every lecture. So you're going to have drug class A, drug class B, and then in these drugs, you're going to have drug number 1, 2, and 3, and their mechanisms of action, the relevant pharmacokinetics, their relevant uses and adverse effects, and so on. And this is how you construct this mental map of pharma in your head. And to take it a step further, if you understand the pathophysiology and physiology of whatever process you're dealing and tackling, pharmacology will make total sense because these sites are the targets of the pharmacological drug. So take it a step further, try to understand rather than just memorize. And lastly, neuro is the mother of crossovers. You have drugs spanning multiple lectures. So neuro pharmacology, take it as anatomy as well. You see how in anatomy you have shout outs of lectures and structures mentioned in many lectures, and they are hinted and foreshadowed and so on. Same goes here. So cross-link information and connect everything together. And lastly, revise, 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 like your life depends on it because you have like 12 pharma lectures. So like you gotta expect maybe somewhere from 12 to 18 questions in the final. Okay? Now, this is my personal notes for pharma, and I realized that this year you have many like the doctors changed for the lectures, but still, for the most part, they stand strong if you want to take a look. Because for me personally, how I study, I take everything from the slides and dump it all in one page. It's always in my face, and I can revise and jump from class to class, drug to drug. And this way, I don't see this 60 slide lecture be intimidating or overwhelming. Khalas, I have them all in one page and it's clearer than ever. All right. So enough of this. Let's actually start with the first lecture, anesthetics. And the way we're going to do this, if you guys are not familiar with my pals, up here in this corner, I have the lecture. And over here, we will first, for pharma, we will get a background, a general basic background of the topic, and then we're going to dive into the drugs. So, for anesthetics, when we're talking about anesthesia, when should a person get anesthesia? Well, when they're undergoing surgery or they have to be sedated for whatever reason. So, anesthesia is the actually, like, what is the definition of it? It's just the loss of sensation with or without the loss of consciousness. Tamam? And it makes sense. When you're doing surgery, you don't want to feel pain. You don't want the patient to be awake to see their body getting opened, right? So you do anesthesia. And you have two groups. You have general anesthesia, where the patient is completely asleep. There's no consciousness and complete loss of sensation throughout the whole body. You can do whatever you want. Cut them in the leg, chest, hands, wherever you want. And because they're unconscious, they don't feel any pain and their muscles relax and they lose their reflexes. And then you have local anesthesia. Let's say I want to operate only on the hand, but I don't want the patient to feel pain. So I will localize this area and locally anesthetize it. Come on, we're just through nerve blocking. So generally, I'm gonna make the patient fall asleep. So I'm gonna target the brain centers that keep you awake and the receptors there. Meanwhile, if it's local, I'm going to target specific nerve endings. تمام? So, when you talk about anesthetics, even in these groups, you have further subgroups. For general anesthetics, we can break them down into two forms, and it depends on how they're administered, inhalational or by IV. You see this in movies when they have to sedate the patient to go into surgery. They put over him a mask and he inhales the anesthetic, right? So you have these anesthesia and then other kind which goes into your veins by IV. Now there are some advantages of IV over inhalational, such as it's much more rapid and it's no pollution, no special equipment. This stuff doesn't really matter, but some disadvantages as well. Because it's rapid, there is no really a reversal to it, and there's always an overdose risk. And by that, because it will cause CNS depression, there is respiratory depression risk, and failure respiratory failure risk. Meanwhile, for local anesthetics, they're broken down into two groups based on their structure, esters and amides, and we're going to talk about what makes them different than each other than the actual chemical property. But both, an easy way to tell if a local anesthetic is ester-based or amide-based is by the number of I's they have. If you have one I, it's an ester. See, procaine, benzocaine, tetracaine. If you have two I's, lidocaine, bupivacaine, and ropivacaine, it's an amide. And as you can see, they all end with cane. Wonderful. Even cocaine technically is a local anesthetic. Right. So these are your general. This is your inhaled, and this is your IV, and these are your local. These are the things we're going to talk about today. And BZD stands for benzodiazepine. We're gonna go through them all. Don't worry. All right. More basics. So the general plan of anesthesia is that you're going to make the patient lose consciousness, relax all their muscles, and lose their reflexes, right? So before that, you're going to prep them for anesthesia. They will fast, they will be put on analgesics, anxiety reliefs, and even muscle relaxants. And antiemetics, you don't want them to be vomiting or aspirate anything, right? And for general anesthesia, the process is as follows. It's three phases. It's a process of three phases. Tamam? Induction, maintenance, and recovery. Now, induction is actually giving them the anesthetic, whether it's inhaled or IV. You see this in movies where they tell or even TV shows, where they tell the patient, okay, now start counting down from 10. This is actually induction, where they go 10, 9, 8, and then they fall asleep, okay? So induction is the period of time from the onset of administration to effective surgical anesthesia. And then you have maintenance. Maintenance is the actual sustained surgical anesthesia, where خلاص, you induced anesthesia, and then the anesthesiologist would maintain a concentration throughout the surgery of the anesthetic. Because two things, you don't want the patient to randomly wake up, and you don't want the patient to overdose. So it's maintaining this perfect balance. And you have something called MAC for inhalation. We're going to talk about it in a second. And lastly, you have recovery. Well, خلاص, you taper off the anesthetic, and it's basically the time from discontinuing it until the patient gains consciousness and return of reflexes. I think they call it binge here. And it's so funny. People wake up, they have anterograde amnesia. They don't really remember what's going on. It's just all that's so goofy. So people mess with them usually, their family and friends. Like MAC, it's something important to mention. It's minimal alveolar concentration, where essentially it's a measure of potency. And the lesser the MAC, the higher the potency. Like again, what is it? Minimal alveolar concentration, alveolar. So lungs. This is only for inhalational. If you say MAC for IV, you're stupid. Sorry. Like, so inhalational anesthetics have this property, the minimal alveolar concentration. So the less it is, the more potent the drug, and you have to give less of it. Halothane is the most potent, having the least MAC, and nitrous oxide having the highest MAC and least potency. Right? Now, duration of anesthesia does not affect MAC. It's not something affected by it. If a patient has anesthesia for 5 days, obviously that should not happen. it will not change either. طيب. Some things decrease this potency, some things increase this potency. Some are pathologic, some are physiologic. Advanced aging, and like these are all the causes, but the ones in bold are the most important ones. Now, advanced aging, pregnancy, CNS depressants like drugs, and IQ alcohol intoxication all would decrease your MAC, meaning a lesser dose is very effective. So, if a patient presents with me and she's pregnant or they have acute alcohol intoxication, I should be careful not to give them too much because they would then, overdose. And things that increase MAC, such as chronic alcohol abuse, okay, it's the opposite. So giving them like the potency decreases, so they need more of the drug in order to induce the effect. So both of them should be careful, taken into consideration and maintained by the anesthesiologist. Okay, this is just a concept. All of the last three is just to give you an idea. We're actually going to the bulk of the lecture in like a minute. Last point, solubility. Now, if a drug is more soluble, meaning it binds to albumin and dissolves in the blood, that drug is not free. It can't go where I want it to go. So it's less potent. Meanwhile, if a drug is less soluble, it's more lipophilic and it's more free. It's not attached to any like globular proteins. It's more potent because it can go where I want it to go. All right, amazing. Now we can move on to our first group, inhalational anesthetics under general anesthesia. So we're still talking about general anesthesia, okay? Now, inhalational, you have halothane, isoflurane, sevoflurane, basically your fluorines, and then nitrous oxide. How do they work? They work by agonizing. Okay, that's so funny to say. No, that's not the right word. By being GABA receptor agonists. Okay, what is a GABA receptor in the brain? It's the major inhibitory neurotransmitter, correct? So whenever GABA is released and GABA receptor is stimulated, you're not gonna propagate the signal anymore. خلاص, you're gonna mute it off. You're gonna inhibit it. So in an awake brain, more GABA will make it fall asleep. تمام? CNS depression. And this is how halogen anesthetics work. Now, nitrous oxide is an NMDA antagonist, which is the glutamate receptor. And glutamate is the excitatory, what's it called? Neurotransmitter, correct? طيب. So both of these processes would work by increasing GABA and decreasing glutamate activity. تمام؟ يعني okay. Halothane, isoflurane, sevoflurane, disflurane, and lastly nitrous oxide. طيب. Now all of these drugs have the same more or less mechanism of action, correct? So what should I know for each? Just simple facts about each Salah, because more or less the use of them and actual choice, that's step 2 stuff and anesthesiologist stuff. Okay, for us, we just need to know a basic factor or two about each. For example, halothane, we mentioned, has the least minimal alveolar concentration, meaning it's the highest potent inhaled anesthetic. طيب? So a small concentration of it would على طول cause or induce anesthesia. However, it's hepatotoxic. And both of these combined effects makes it rarely used anymore. تمام? Isoflurane, okay, it's pungent, meaning it doesn't smell nice, and it can cause vasodilation, meaning it can decrease blood pressure and cause hypotension. You see the lowercase h? Hypotension, not hypertension, okay? It's a lowercase h. So, we wouldn't really give this to a patient with shock. Now, sevoflurane, and I'll explain this later with other examples, but for now, just keep this in mind. Now, sevoflurane and desflurane are important because they're most used. Sevoflurane is most used to induce anesthesia in children. Remember the induction phase? So an anesthesiologist would start off with a dose of sevoflurane to induce it. And then once that is tapered, خلاص, we induce the anesthesia, I can then introduce desflurane to maintain my anesthesia because it has a low blood solubility and it has a fast onset/recovery. Okay, it's safe to use. Nitrous oxide is the polar opposite of halothane. It has the highest MAC, meaning it's very weak, not like very low potency. تمام? And not, I mean, theoretically not ever used. Like all of these drugs all of them have a very unique side effect or possible adverse effect, which is malignant hyperthermia. If you guys remember from your MSK block last year, this is a condition where this is a mutated kind of disease, all right? Not everyone will have this. It's a mutation in the ryanodine receptors or L-type calcium channels, where you have an overactivation whenever you have the use of muscle relaxants, such as succinylcholine. All right. So let's say, if you remember, in anesthesia, pre-anesthesia, we give them muscle relaxants, usually succinylcholine, to relax their body and take the anesthetic in. If we give succinylcholine and then our inhaled anesthetic, there's a high chance, or there is a chance, if a patient has this mutation, to develop malignant hyperthermia, where they will have hyperthermia, muscle rigidity, tachycardia, acidosis. It's an emergency. Now, if this patient, so every surgeon and anesthesiologist on board, whenever administering both, should look for like this kind of reaction. If this reaction is present, there is an antidote. You give them dantrolene. If this reaction is not present, this person does not have this mutation. It's that simple. This person is free of this mutation. All right. This is a very high yield concept, and dantrolene gets asked a lot. So keep it in mind. I remember we saw a couple of questions of it over the years. All right. As for pregnancy, if you have a lady and she's pregnant and she has to do surgery, or she's in labor and she wants to do an epidural, all right, remember, pregnancy decreases back, meaning a lesser amount of anesthetic would induce anesthesia, and that should be maintained, like considered, tamam? And if a person is undergoing epidural anesthesia, this lady needs epidural, we don't usually do general anesthesia. We give her a localized anesthetic, usually bupivacaine. We're going to touch upon it later on in the localized anesthetics. All right. Continue with general anesthesia. We have IV anesthetics now. All right. So general, inhalational, we have potential for malignant hyperthermia, and you need to know which one is for induction in children, which one is for maintenance, and which one is the highest MAC, lowest MAC. All right, easy stuff, inshallah. For IV, they more or less work the same, mechanism of action-wise, and we have the following drugs: propofol, thiopental, etomidate, ketamine, and benzodiazepines. طيب. Now, all of these drugs, again, they work more or less the same, but let's just break it down further. Propofol, tamam, would potentiate GABA receptors, forming like further CNS depression and so on. It also has antiemetic properties, so it's a very favored anesthetic. Remember, we should also give them antiemetics. Now, it has rapid onset recovery, hepatic metabolism. Most importantly, it causes vasodilation. Again, it could cause hypotension. Why? So, like, this should be contraindicated, or we should not really prefer the use of this drug in a person who's undergoing shock. Let's say a person got into a car accident and they lost a lot of blood and they're still awake somehow, and they are under hypovolemic shock. All right. They come in, you want to do surgery, now they're doing anesthesia or whatever, and you give them propofol. This could, like worsen their symptoms and cause a lot of complications. So keep it in mind, it causes hypotension by vasodilating the arteries and veins. Right? It can cause respiratory depression as well. And usually, like there's no analgesic effect of propofol. It's just alatul sedation. Sorry, hypnosis. Like it's induction gold standard. Tamam. Whenever you give IV, because of its rapid onset, خلاص, you can induce anesthesia على طول and then move on to maintenance. And that's the most important things you need to know for propofol. Thiopental, again, same kind of idea. However, it's a barbiturate. And we're going to touch upon barbiturates in another future lecture, where it's another crossover kind of drug. So, adverse effects is CNS depression, and again, it can cause hypotension. But most importantly is respiratory depression. We're going to talk about that somewhere else. Again, induction, but because of its barbiturate nature, where it can cause severe CNS depression and further on respiratory depression, it's rarely used because of its minimal risk index, or therapeutic index, sorry. We have more safer options to use. Etomidate is used in hemodynamically unstable patients. طيب, again, this patient who had an accident and they have hypovolemic shock. I need to put them under anesthesia, right? What should I do? I can give them etomidate instead of propofol or thiopental. Amazing. And its adverse effects, adrenal suppression, pain on injection, myoclonus, and so on. So it's not used for a long time because of mainly the adrenal suppression. It's a very important side effect. All right. Now I know, unfortunately, a lot of what I'm saying feels like I'm just reading off of the slides, but I'm really trying to make as much sense as much as possible. And later on in the other slides, it's better. This first lecture is kind of slow, but really pharmacology, because there's a lot of adverse effects and pharmacokinetics and so on. You need to just repeat it to yourself a lot of times and try to make sense of it on your own. If mnemonics work for you, amazing. If Anki works for you, perfect. Do Anki as much as you can. All right, that's my advice. Ketamine is a very weird drug because its indication is for dissociative anesthesia, and dissociative anesthesia is insane. It's basically you can't feel your body while you're awake. All right, it's anesthesia. It's general anesthesia without the loss of consciousness. How cool is that? All right. For example, brain surgeries, and you see them still awake and so on. So yeah. Now the way it works is a bit different. However, because it's similar to nitrous oxide, meaning it's an NMDAR antagonist, which will again cause CNS depression, and it also has analgesic effect, طبعا, and other things it does where it has sympathomimetic effects and activating K channels, where they manifest an adverse effect. So you can have increased heart rate / blood pressure due to the sympathomimetic effects, increased intracranial pressure, increased intraocular pressure, and so on. So you don't really give this to a person with glaucoma, for example. And it can cause hallucinations and nightmares. Benzodiazepines are the goats of neuro. If you ask me, there are two goats of neuro, benzodiazepines and SSRIs. They are everywhere. They have so many uses. They are incredibly powerful drugs. And we're going to talk about them in great detail further on in lecture 4. So over here, you only have two drugs of benzodiazepines you need to know, midazolam and diazepam. The diazepam is the main benzo. And the way they work is simple. GABA receptor potentiation, we're going to explain exactly how later on. And it's an anxiolytic, and also it causes amnesia, muscle relaxant. It's the perfect, in many scenarios, it's the perfect anesthetic. All right. Some adverse effects, however, respiratory depression. But it's reversible. We can give the person flumaxazole if that happens, if severe respiratory depression occurs. However, if we're talking about thiopental, the barbiturate, this can't work because we don't have this antidote. A patient can go into respiratory depression and khalas, it's over. And obviously there are ways to try and maintain and stabilize the patient, but it's very, very dangerous. All right. And I think this is it for our IV anesthetics. Now we can talk about localized anesthetics. All right. So in localized, if you guys remember, we had two groups, esters and amides, and I want you to focus on lidocaine, bupivacaine, and procaine. طيب, how do they work? How am I locally suppressing nerves or something? Basically, they block voltage-gated sodium channels. By doing so, no sodium enters the neurons, no action potential is generated, and the signal is cut. It doesn't transmit. صح? Now, it works well in most tissues, but if the tissue is infected or there is acidosis or something, it's not as effective. تمام? So let's say there's an abscess somewhere or there's a soft tissue infection over the arm and you need to locally, use a local anesthetic on it. It doesn't work well, unfortunately. So pharmacokinetic wise, now all of them have the same mechanism of action. تمام? pharmacokinetic-wise, which is really interesting. You remember these two groups that we have, esters and amides. Now, these two are like organic chemistry groups, صح? هلا esters, which have one I, as we said up, they have a metabolite, which is the PABA. Now, PABA is antigenic, meaning that if we use esteric or ester localized anesthetics, we can develop allergic reactions in people, hypersensitivity reactions, antibody formation, and so on. So, amides, where they don't have this antigenic metabolite or whatever, are safer. طيب? They don't have this kind of risk to them. Esters have a much shorter half-life and they are metabolized in the plasma. Meanwhile, amides, they're metabolized in what's it called, the liver cells, and they have a longer half-life. طيب, administer with epinephrine sometimes. This is just like an extra fact. Again, focus on lidocaine and bupivacaine, which both are amides. طيب, Procaine, just keep it in mind as an ester or like these I's. So again, the nice thing about localized anesthetics, they have the cane prefix, suffix. All right, they have the cane suffix. Even cocaine is considered a localized anesthetic, but for some reason this was omitted from your lecture. Only us last year. طيب, lidocaine is the goat. Lidocaine is my love. طيب, why? We use it in a lot of things. Topical anesthetic, nerve block, and it's also an antiarrhythmic. You'll take this more in CVP. But basically, if you're doing a lumbar puncture, if you're doing male catheterization, you give them lidocaine. It's great, it's local and amazing. طيب. However, we have some side effects, and some are presenting early and some later. Now, both of these, lidocaine and bupivacaine, have cardiotoxic effects. Lidocaine is milder, bupivacaine is very severe, and we'll talk about it. طيب. Firstly, adverse effect of lidocaine at the start, you have CNS toxicity, where you just have, numbness, tinnitus, seizures, drowsiness. This is just like, some basic side effects of using the drug. Now, of the systemic like spreading of the drug. Now, the cardiac factor, you have bradycardia, hypotension, arrhythmias, cardiac arrest. Remember, it's an antiarrhythmic, but still, it can cause these problems as well. So it's just it's a weird, confused drug. For the most part, it's very effective and very commonly used. طيب. And if we have with lipid emulsion, both of them, all right, they could be administered in many ways. IV, see in third year. For now, let's move on to bupivacaine, where it's very interesting because it's the potent local anesthetic. It has a very long duration, 3 to 8 hours almost, and a slow onset. طيب? And it's very lipophilic. Remember what we said about lipophilic? They have a higher potency. That's why. هلا. We use bupivacaine mainly for epidural anesthesia. Remember when we talked about pregnancy and inhalational anesthetics, where we talked about the MAC. Now, bupivacaine is used for epidural anesthesia, spinal anesthesia, other stuff, but this is the most important one. Again, adverse effects, cardiotoxicity risk. The most cardiotoxic. It's the most potent and most cardiotoxic. And because it has a very long duration, it stays in the body a lot. And because of its high lipophilicity, it binds tightly to cardiac sodium channels, slow dissociation. Blah, blah, blah. Basically, just know it's very cardiotoxic and it should be carefully monitored in patients with CVS disease. All right. With this, we finish anesthetics. This is all for your own review. And now we move on to opioids. Again, let's take a brief recap background of opioids. What is opioids? Opioids are basically, you have something in your body called the opioid receptor. Now, whenever your body feels pain in the nociception pathways, sometimes you get an injury and you get pain from the injury, right? Like pain is a survival mechanism. Sometimes people, they get an injury, but they don't die from it, but they die from the pain, the extreme pain it causes. So your body has this loophole where they calm down the pain a little bit by the opioid receptor. The opioid receptor is a natural receptor in the body intended to decrease pain signals or just to numb things out. We have three kinds, mu, kappa, and sigma, and they are, just distributed all across the body. Most importantly, we're going to discuss the mu receptor, where it's found in the spinal cord and the thalamus, and basically PNS and CNS. طيب, how it works, the opioid receptor is a G protein coupled receptor. So it's gonna just inhibit animal cyclase, decrease cyclic AMP, and it's gonna prevent or decrease the pain neurotransmitter releases, substance P, all these kind of stuff. And post-synaptically, it's gonna hyperpolarize opening K channels. This came in our exam. It was important. It's important to distinguish the presynaptic effect and the postsynaptic effect. All right, keep this in mind. Understand it very, very well. What are the effects of activating a mu opioid receptor? By doing so, we're going to have some CNS depression, but basically respiratory depression, analgesia, as we said, this is the main function. It can also manifest in dependence, sedation, euphoria, decreased GI motility, and meiosis. The kappa receptor is more or so the same, but it manifests in dysphoria and lesser extent both of these. And the sigma receptor is not really in our best interest right now. In the body, the natural peptides and dynorphins. Now, endorphins manifest at the, the mu receptor, enkephalins at the sigma receptor, dynorphins at the kappa receptor. And enkephalins, they have an effect of at nociception at the spinal and supraspinal level. I'm going to explain what those levels mean. So, when we're talking about opioids and the way they work, you have the mu and the kappa receptor. That's amazing. Now we know how they work, what they do, and so on. Now, if I want to introduce a drug, and so on. So my goat, morphine, and these like substances are all opioid agonists. And the way they work, they would bind on these receptors and induce supraspinal analgesia and spinal analgesia because we use opioids mainly as painkillers. We don't use them really for their euphoria, for painkillers at the CNS level. And that is very important to understand. So again, let's talk a little bit about the spinal thalamic tract. Let's say you feel pain in your finger. So that signal will go into the dorsal root ganglion for the first body neuron, and then it will, transmit a signal, decassate through the spinal cord into the second body neuron, up to the thalamus for the third body neuron, and then to the sensory cortex, right? And then the signal would go back, confirming the pain. So if I'm talking about supraspinal analgesia, it's going to work at the descending modality pathways to the dorsal horn. So cutting this part off. The way it works, if I'm not mistaken, there is a tonically inhibited GABAergic, a GABAergic neuron somewhere in the brain that would inhibit the receptor activation. And when you tonically inhibit the GABA would then work and the pain would then be inhibited. All right. And then if we talk about spinal analgesia, it works at the down level. Let's actually move on to the important bulk of this lecture, the actual drugs. Starting with the main setter or the main example of the night, which is morphine. Now, more or less, all these drugs work the same. They are mu kappa receptor agonists. And we just mentioned how the receptor works. G protein coupled receptor, decrease CAMP, and decrease neurotransmitter release. So this is how morphine works. And by so, I'm going to get the following effects. Spinal and spinal analgesia. I'm going to have euphoria from the mu receptor. I'm going to have respiratory depression a little bit because of the reduced respiratory rate. And it will manifest in reduced respiratory rate and less sensitivity to arterial partial pressure of carbon dioxide. Another interesting thing for morphine, it's going to have a depression of the cuff reflex. And in your CVP block in third year, we're going to have a lecture about these kind of over-the-counter drugs. And there's a class called antitussive, which is cough suppressants. And one of them is dextromethorphan, which is a opioid. How does it work? It depresses the cough reflex. Just keep this at the back of your mind. Codeine and full codeine also have the pinpoint pupils. Very important. You're going to have decreased GI motility. It's antidiarrheal. And in GIT in third year, you have a drug called loperamide. Are these drugs important for neuro second year? Not really. It's so low yield صراحة. If a question comes from here, what did you guys do to them? And it can also secrete some histamine release. All of these effects, guys, I want you to understand, all of these effects, the activation of the mu receptors. I'm not bringing this what morphine does. And you're going to understand the adverse effects. So, adverse effect number one, exacerbated, such as being of the elderly, obesity, sleep apnea, and so on. Are they important? In the transcription, it said you need to know them. So yes, keep them in your mind. And then you're going to have something paradoxical. Hyperalgesia. Now we said opioids are painkillers. Why are we, intensifying the pain all of a sudden? Hyper? For prolonged opioid exposure, prolonged, not tolerate, just prolonged, like I'm giving you an opioid for 10 hours straight, you're gonna start reverse. It feels better, or what am I saying? It improves after cessation or dose reduction. You're gonna have nausea, vomiting. You're gonna have urticaria because of the histamine release, pruritus, bradycardia, hypotension, and pethidine and fentanyl. However, do not produce this effect. So these are again morphine opioid derivatives or so, either synthetic or natural. You're gonna have dysphoria and hallucinations from the kappa receptor stimulation, and it's not really a favorable effect, so it's in the adverse effect. And for indications, when do we need painkillers? If we have acute pain or cancer pain. However, it's not given for neuropathic and chronic pain, as these are different. Lastly, pharmacokinetic. These drugs are available orally. You can see many people popping pills, Vicodin, whatever it is, and they are all metabolized in the liver. A patient with liver problems, any opioids are a hassle to them. Guys, understand morphine, understand mu receptors, and everything else makes easy sense. It's so easy. And the adverse effects are just the bad effects of the mu receptor, all right? If I have opioid overdose, if I have so much opioid in my system and the patient is intoxicated, what should I give them? I should give them an antidote, an opioid receptor antagonist, and that is naloxone for me, all right? Now its affinity to mu receptor is the greatest, and then kappa, and it's the first line for opioid overdose. It can even reverse neonatal respiratory depression caused by labor analgesia. We'll get to this later on when we talk about pethidine, and even reverses it for buprenorphine. And generally, it reverses respiratory depression for any opioid, but you need the higher dose for buprenorphine. I'll explain this later on. Pharmacokinetic, you give this IV. You don't have oral naloxone. You should administer it IV, and it's a fast onset. And you have a patient, they have these symptoms, give them naloxone, khalas, easy fix. And there's no adverse effects. If a patient is acutely on opioid, let's say they're going surgery and they take so much opioid for the pain, they're gonna not feel any adverse effects. However, if this person is an abuser and they abuse opioids, they're gonna have acute withdrawals immediately, because this will flush out the opioids from their system. So we have opioid antagonists and agonists. Naloxone is our antagonist. It's like an antagonist agonize my mu receptor and my kappa receptor. And you have another one, naltrexone, which is for alcohol withdrawal. And you're going to study this, I believe, in your CNS stimulants later on, but I wanted to mention it here. And you have pentazocine, which is a drug not mentioned in your lecture, but was mentioned for us last year. It's a partial agonist antagonist, so hyphen. And then you have obviously your opioid agonists. Morphine being your base, and then all of this. Like, damn, I have what? A lot of 10 opioids, and I'm supposed to memorize all of them? How? Bear with me. I came up with a mnemonic, and I'm صراحة يعني, it's my first time ever coming up with a mnemonic. I suck at this. However, just here we go. يعني. Here goes nothing. Don't cook opioids. House failed. Reach, but bear with me. And I want you to take the commas into consideration. So the commas join both the word before it and after it. So opioids and house are joined, and failed and reach are joined. And you can understand why. So don't cook opioids. House failed, reach my pure triangle basket. Don't for die morphine. Heroin. All right. D. Cook codeine. Opioids and house, because of the comma, they're joined. So we're talking about oxycodone and hydrocodone. And hydrocodone and house are a match made in heaven. I'm going to show you why later. Now, failed and reach are joined. So we have fentanyl and remifentanil. And then my for methadone, pure for pethidine, tramadol for tramadol. Like, yeah, I got lazy there. And then basket for buprenorphine. If this works for you, I'm so happy. If this makes you cringe, I'm so sorry. I tried. All right. So they all have the same mechanism of action. They are mu receptor, kappa receptor antagonists. Starting with diamorphine, don't. It's heroin. Like, have you ever seen heroin being given to patients? Not really, because it's an illicit drug. It's a drug of abuse. It acts very rarely. So we can only give it صراحة, and they're dying from cancer. خلاص, get them high, like it's over, يعني haram. Give them some heroin, all right? So don't cook codeine. And the important thing to know about codeine is it doesn't cause euphoria. It's a pure analgesic. Little to no euphoria. You give it by oral, and it's a prodrug. There are two prodrugs you need to know and keep in your mind. Tamam? It may cause constipation and really addictive because of the no euphoria. Tamam? Moving on, oxycodone and hydrocodone. Now, if you watched House, you'd see him take this pill called Vicodin. Now, Vicodin is hydrocodone plus, if I'm not mistaken, acetaminophen. I'm not sure. So my go House right here is on hydrocodone, an opioid, perfect. So don't cook opioids, House. It's a major drug of abuse. Remember, House abuses Vicodin out, and you give it for acute pain and severe pain. Well, fentanyl and remifentanil failed and reach. And the most important thing you need to know is that fentanyl is very potent. It's a very dangerous drug. And if I'm not mistaken, there was some weird mall attack in Russia. Dr. Dilip told us about last year. And it was weird. Look it up, like 1980 something fentanyl mall attack in Russia. So fentanyl is much more potent. It's a major drug of abuse. So we don't really use this much. However, it can be used in anesthesia and patient control anesthetic for the analgesic effect. And it's given with benzodiazepines. This was not mentioned in your lecture, but I remember it was important. And it doesn't cause histamine release. Come on. Moving on, methadone, you need to know that methadone is very slow. It has a very long half-life, meaning I can use it for maintenance of opioid users. If I have a patient who's trying to, quit, خلاص, they don't want to be addict anymore. I can put them on methadone so they don't go into withdrawal immediately. So thanks to its long habits. And lastly, pethidine in this slide, it's used again for labor analgesia. Remember when we said that you can give naloxone to reverse respiratory depression in kids, in labor kids? It's because of pethidine. You give it in labor analgesia. So you can give an epidural, which is by bupivacaine, anesthetic and analgesic. And naloxone may be needed to reverse. However, pethidine and fentanyl do not cause histamine release. And codeine is a prodrug. Remember this. Doesn't cause euphoria, it's a prodrug. There is another prodrug, and this prodrug is special. It's weird. Tramadol is metabolized by something called CYP2DX. This cytochrome liver enzyme can have like major phenotypes, a wide mutation possibility. So some people have higher activity of it, some people have lower. If the patient have a high activity of it, they will metabolize more tramadol, deeming it more active and increasing the effect of it. And with lesser active CYP2D6, we're going to have weaker analgesia because less tramadol is being processed. So some people, I'm going to give them more, some people I'm going to give them less. And these people will be flagged, they will be monitored and so on. And something special about tramadol as well, it doesn't cause respiratory depression. And that is phenomenal. However, it can cause convulsions, histamine release, meaning urticaria, and these kind of stuff, and some hypotension, all right, if it means prior to it. It can inhibit the reuptake of norepinephrine and serotonin, meaning there's a slight chance of serotonin syndrome. Now, lastly, my buprenorphine, it's colored in yellow, different than the others because it's a bit different. It's a partial agonist at mu receptors. So, because of its large structure and partial activity, again, I can give it to maintenance, to like the maintenance therapy of now buprenorphine because of its large structure and weird, binding activity with mu receptors, reverse, let's say, respiratory depression if caused. So I need to give a much higher dose of naloxone to suppress the respiratory depression caused by buprenorphine. Phenomenal. And with this, whenever we talk about any drug or any kind of therapeutic that can cause addiction, there are three definitions we should understand: tolerance, physical dependence, and addiction. Tolerance is just tolerating the drug more. Yani more and more, every time I take a dose, it doesn't hit anymore. I need more of it. And by doing so, it's due to the desensitization and the downregulation of my receptors, I can fall into the trap and consuming more and more of the drug. Physical dependence is I can't live without this drug. I'm going to fall into withdrawal. Without it, I feel weird. I feel less. And withdrawal of opioid is important because any drug of addiction manifests differently in its toxicated form and its withdrawal form. So when you have, for example, benzodiazepine withdrawal, it's different than opioid withdrawal. It's different than amphetamine withdrawal. It's different than cocaine withdrawal. All of these you should understand and know in order to tell the differences. Now, we said opioid will have euphoria, sedation, analgesia, and pinpoint pupils, correct? Reverse all of these. We're going to have increased pain. We're going to have agitation. We're going to have dysphoria, dilated pupils, increased blood pressure, diarrhea. All of these are just the reversal because, khalas, I'm dependent on this blood. My body can't work normally. And lastly, addiction is the compulsive use of these opioid drugs. So tolerance and physical dependence lead to addiction. not the other way around. I hope this is helpful in any way. And now we move on to drugs for migraine. Very cute, simple lecture. Like we talked about anesthetics, we talked about opioids, we talked about falling asleep, and we talked about painkillers. Migraines are like this form of headache condition that just manifests, and it's the most intense headache you can ever feel, and can even have other symptoms and neuropsychiatric, implications. Like if you didn't know, it's inherited, more commonly in females, and it's a recurrent severe kind of headache that is either throbbing or pulsatile. You can also have nausea, vomiting, photophobia, and phonophobia. Now, it's episodic, lasting 4 to 72 hours. And if it's more than 72 hours, we call this status migrainosus. Chronic migraine is headache at least 15 days per month, which is insane. That's like a headache every 2 days. And migraine without aura is the most common. Now, a migraine has 4 phases: prodrome, aura, headache, and postdrome. And all of them have different kind of symptoms, where prodrome usually occurs where, let's take aura as our reference point. So 72 hours before the aura is our prodrome, where the patient just feels irritable, has weird food cravings, mood swings and fatigue, and just general phobias, some negatives. Aura is 5 minutes to 1 hour right before the headache. And if a patient has aura, remember the most common migraine is without aura. But if a patient has aura, this aura is either visual, auditory phenomena, just psychiatric, kind of hallucinations, flashes of light, objects, tinnitus, music. It's not real. It can last from 5 minutes to 1 hour. And then comes in the headache, the actual migraine, which is awful, throbbing and pulsatile, and can last from 4 to 72 hours. More, we call it status migrainosus. And lastly, the recovery, the postdrome, the post headache, where you're gonna feel very weak, tired, and you don't have any appetite. And phases may overlap. You may have aura symptoms with prodrome, you may have headache with postdrome symptoms, and so on. So it's not really fixed for every person. So how does it happen? What is the pathophysiology of migraines? Now, migraines is not covered in any of your pathology lectures or maybe one neurology lecture. So pay attention here. Now, it's hypothesized that the actual beginning of a migraine is by primary neural dysfunction affecting hypothalamus and thalamus. The migraine, head pain, is innervated by the trigeminal nerve. Because the scalp and the skin and so on, this is all the area of the trigeminal nerve. You're going to have this dysfunction, and you're going to have this cortical spreading depression, which is the aura phase, propagating, which is a propagating wave of depolarization across your cerebral cortex. And this kind of once it reaches the trigeminal nerve, it would activate these sensory endings, and it would release neuropeptides such as CGRP, calcitonin gene related peptide, and substance P. All of your vessels would start to vasodilate. Let me once again do this. Okay, never mind. So once you have this vasodilation, you're going to have also neurogenic inflammation, activating further the trigeminal vascular system. And another hypothesis is that a neurotransmitter called serotonin, which works in so many different ways, will constriction. So let's say if they don't have enough serotonin, they will not have this vasoconstriction effect. They will have vasodilation, like a prominent vasodilation effect. And it may facilitate the activation of this system, or pathway. And lastly, the neurons become increasingly sensitive to nociception and non-nociceptive, producing this pain, headache, and so on. So to sum it up, you have the trigeminal vascular activation, the nociception sensitization. All of this underlies the headache phase of the migraine. So I have a patient a migraine. How do I manage them? What do I give them? You have two approaches, abortive and prophylactic. Abortive meaning this patient is undergoing a migraine this second. I need to free them. I need to save them. I need to manage their acute pain and symptoms, relieve them. You have prophylactic, meaning I don't want this patient to experience a future migraine. So, abortive, you have these following drugs, starting with the first line, which is analgesics and SAIDs and acetaminophen, where are basic painkillers. However, if they don't work, then you move on to the selective treatment, which is triptans, lasmiditan, and the other we're going to talk about. And this is the order of the importance. And like realistically, triptan is the first line, but you still give analgesics, NSAIDs, and acetaminophen. And then triptan doesn't work, you move on to lasmiditan, CGRP, and ergots. Like we're talking about pain. Why not give them opioids? We've just been talking about opioids. Well, opioids work at a CNS level, صح? And migraine is this inflammation process, vasodilatation, and so on. So opioids here aren't as effective, and we're not gonna, and yes, we can maybe relieve the pain a bit, but we're not managing the symptom. The vasodilated artery is still like pumping and pulsating. So I need to relieve that in order to get an actual like therapeutic effect. So they're not really recommended here. Now, in my prophylactic, I have the following drugs. And more or less, we don't really understand how they relieve or like how they are acting as a prophylactic. But lifestyle modifications prove to be very important in like suppressing a future migraine. If you sleep well, because sleep deprivation is a trigger. If you have a regular meal schedule, because hunger can trigger the pain and a migraine, and exercising is always beneficial. Right? Just keep this in mind. It was emphasized on in your transcription. Let's start with the first class, which is triptans, and it's the most selective to the pathophysiology. We just mentioned that if we have like a decreased amount of serotonin, we're not going to have this vasoconstrictive effect, and vasodilation takes over. So triptans are selective or just generally stimulating receptors. We're going to have vasoconstriction of the trigeminal vascular systems and inhibiting the release of inflammatory neuropeptides, which is perfect. We're suppressing the pathway, the pathophysiology. We have an oral and subcutaneous formulation, because if you remember, the patient could come with nausea and vomiting. So if we can't give anything orally, we can give them the subcutaneous or rectal or even nasal formulation. It's metabolized in the liver, short half-life. The adverse effects, they're mostly very managed. So what we should actually focus on are the contraindications. Now, because we're giving serotonin, we can't really give this to a patient with a history of CVS, cardiovascular disease, because when we're talking about serotonin, it can cause in the CVS system coronary vasoconstriction, contributing to platelet aggregation, and even a possible role in coronary artery spasm. A patient with chest pain, ischemic stroke, or even hypertension, they all are at risk of exacerbating their symptoms. And Allah, morbidity. Keep this in mind. They're safe, but they're not severe. And if a patient was taking monoamide inhibitors and SSRIs, which again further, increase the amount of serotonin in the body, we can have, or like there's the risk of developing serotonin syndrome. Anytime you have a risk of increasing the amount of serotonin in the body, you can have the risk of serotonin syndrome. So keep this in mind. Right? And lastly, so again, we said this about tramadol, remember? And lastly, you should never give this or should not be used with like hydroergotamines, which is another group of anti-migraine drugs. All right, so again, it's a serotonin 1B, 1D receptor agonist. It will vasoconstrict, inhibiting neuropeptide release. However, we should understand serotonin effects on the heart and the CVS system in general. So we should not be giving it to CVS patients and patients on monoamine oxidase inhibitors and SSRIs. All right, or ergots. Now, moving on to the alternative abortive agents. because again, I didn't say it, these are abortive agents. We're not talking about the prophylactic treatment. This is given during a migraine attack. We have lasmiditan, which works kind of the same. However, it's more selective, where it only targets the 1F receptor agonist, sorry. And it would then, again, vasoconstrict, releasing neuropeptide release and so on. But a very important side effect is dizziness. So if a patient is, like, let's say, a truck driver and they have migraines, we can't really give them this like drug because they're driving, and if they feel dizzy, they may like get into a car accident. So we should always remember the dizziness side effect of lasmiditan. Hence this, I don't know, like cartoonish dizziness. Play it. Nicely enough, we can give this to a patient with cardiovascular like disease in general because it's safer and it's more selective, hence. And you get me? And basically 1B and 1D receptors are also found in the heart, but 1F receptors are not found there. That's why this is more selective and more safe. And it's alternative therapy. If triptan, the first line, does not work, we move on to lasmiditan. Like if this doesn't work, or the patient can't really take it, we can give them CGRP antagonists. And because CGRP is a protein, we should really target it with a monoclonal antibody. طيب يا عيني. You see the MAB and MAB over here, erinimumab, ferminemumab, and eptinimumab. All right, we either can target the receptor or the ligand. Erinimumab, numab, targets the receptor, and zumab targets the ligand. The ligand, zumab, the ligand. And by doing so, it's going to prevent further vasodilation caused by CGRP, releasing the release of neuropeptides. Yeah, we can give it intramuscularly, IV, subcutaneous, and it has a very long half-life. So we can give like one injection every couple of months. You get me? Beautiful. Oh, there's a bit more. However, because it's a monoclonal antibody, we can have the following normal adverse effects of any monoclonal antibody. Increased reaction, cytokine release, antibody development, hypersensitivity, CGRP, very long half-life, one injection. We can either target the ligand or the receptor, and just monoclonal antibody, antigenic, allergenic interaction side effects. Anyways, indications of CGRP antagonist, we can use them as abortive and prophylactic at the same time. And it's used in all types of migraine. Beautiful. Moving on to the last two remaining abortive agents, we have ergots and we have anti-emetics. Because remember, when we're talking about migraine, remember the migraine symptoms: nausea, vomiting, phonophobia, photophobia. We should also manage the nausea and vomiting, so we can give anti-emetics, anti-vomiting agents. And these are all in صراحة very more relevant in GIT, third year. Just keep them at the very back of your mind, but kind of the same to triptans. However, they're less safe, basically. Why? We're going to talk about that. هلا, again, 1B, 1D receptor agonists, vasoconstriction, we know this. And half-life is relatively longer, IV, subcutaneous. We don't have an oral formulation. The only oral formulation is for triptans, but we can't give them with triptans. They're contraindicated because they both would exacerbate the levels of serotonin, and they're going to have serotonin syndrome. So you should never give them together. Like adverse effects. Why is this drug not really preferred? Because it can cause prolonged vasospasms. So خلاص, we vasoconstricted it, but then because of its non-selectivity, it can go into 1B, 1D receptors in the bowel or anywhere else, and like weird cases, the heart. And over there, it's going to cause this prolonged vasospasm, and Allah, it's going to cause ischemia and like thrombosis and so on. Like, and it can also cause GIT disturbances. It's not really as important, but because of this prolonged vasospasm, we should not give this in a patient with ischemic vascular diseases. Let's say a patient has ischemic bowel disease or something. We should not give it. Where do we give ergots? Ergots are cheap. They're cheaper than triptans. They're cheaper than monoclonal antibodies, of course, and they're cheaper than lasmiditan. So if a patient doesn't respond to triptan and they are a young female and they don't really have cardiovascular disease, we can give them a dose of ergots. Yalla, and let's see what happens. Because no other options are available and no other options are working, and it's the fuse. Beautiful. Antiemetics work by inhibiting dopamine, and they blockade the receptor, and we can give them IV, intramuscular, or even oral. That's all you should know about them. For now, that is your abortive treatment. You start them off with acetaminophen or NSAIDs. The pain is extreme. You move on to triptans, or like a patient خلاص is diagnosed with migraines, you put them on triptans على طول. And you don't need to memorize all the triptans, sumatriptan, zumastriptan. No, it's in the name. It says it's a suffix triptan. And triptans work by, again, 1B, 1D, it's just more serotonin receptors and so on. And then you're going to move on to lasmiditan because it's more cardiovascular safe, but it can cause dizziness. So if a patient can't take that, we're going to put them at their and they can afford the monoclonal antibodies. We're going to give them on CGRP antagonists. And if all of these don't work, we're going to put them on ergots. And of course, we're going to give them also the antiemetics. That is your abortive. What about your beautiful prophylactic treatment? This is the crossover of all crossovers. We have beta blockers. We have tricyclic antidepressants. We have serotonin and norepinephrine, just more reuptake inhibitors. You have anti-epileptic agents, all right? Propranolol, amitriptyline, topiramate, and all of these, we're going to talk about them later. And one which is not mentioned in this lecture, but mentioned in the future, gabapentin, an anti-epileptic, is also prophylactic for migraine. How do they work? Yeah, any more or less, they prevent vasodilation caused by CGRP and other stuff. Like, propranolol has the strongest evidence, so it's the best to be given for prophylaxis. Now, they should be daily, and they should be assessed from a period of 3 to 6 months to see whether they're working or not. So we give, let's say I have a patient, they experience their first ever migraine. I give them acetaminophen, I give them triptans, and then, okay, khalas, the episode passed. I'll give them propranolol, daily dose, and obviously I'm going to take into consideration any kind of comorbidity. And after 3 to 6 months, I'm going to see how many migraine attacks have they been taking? Have they got? Is the prophylaxis working or not? An important concept here, however, is you'll never have a perfect patient. Patients come with multiple comorbidities, multiple diseases. So if I have an asthmatic patient, I'm not going to give them propranolol for their prophylactic migraine treatment. Propranolol will make their asthma worse. I'm going to give them another one, topiramate, maybe amitriptyline, venlafaxine, whatever. So maybe I'll get an MCQ and I'll see both prophylactic options. Which one works better? This is where I should use my brain. And this question came to us in the final. So use your brain and try to remember things you took in POD, things you took in MSI, okay? Every block, build up this foundation of pharma and keep building on top of it, because later on, when you go to the steps, you're going to do all of this all over again. Or if you're doing the Saudi board or the British board, whatever you're doing. Enough tangent, let's go back. Again, the indications of all of these, above the lifestyle modifications, are for your prophylaxis and when abortive therapy fails, and if you have chronic migraine. However, if it's so severe that khalas, the prophylactic even isn't working, a very insane drug to treat things where it will mess up at the neuromuscular junction, the acetylcholine releasing, by the neuromuscular junction and other nerve ending junctions. Where it will, like trigeminal fibers, you will relieve the neural activation and the release of neuropeptides and further the migraine. SubhanAllah, some trials showed some effect of this, but still more research should be done. So just keep this at the back of your mind. Interesting bit of medicine, right? So again, this is your migraine, prodrome, aura, headache, postdrome. And now let's split it up. This is when I'm gonna give my prophylactic treatment, my lifestyle modification, my Botox, No, sorry. Botox is only for chronic migraine. But still, my lifestyle medications, my propranolol, even CGRP could work in both. And here is where I'm gonna give my abortive treatment. NSAIDs first, then triptans your first line, lasmiditan, CGRP, ergots, blah blah blah, anti. And with this, some summary for you, we move on to sedatives and hypnotics. This is my favorite lecture. Weirdly enough, it's very interesting, so let's jump in. So, first of all, we talked about three conditions so far. A patient going into anesthesia, which is more so physiologic than pathologic, painkillers, opioids, migraines, headaches, and now we're going to talk about patients who can't sleep and patients with anxiety, let's say. So you have these two problems, and we have two kind of drugs, sedative drugs and hypnotic drugs. Now, weirdly enough, sedative drugs don't make you fall asleep. They only reduce anxiety. It's the hypnotic drugs, the hypnosis that actually makes you sleep. All right. And the most important takeaway here is that GABA is the major inhibitory neurotransmitter in CNS. Whenever I want to depress my CNS, I take GABA. Whenever I want to stimulate my CNS, I'll take glutamate. Like, before talking about the drug classes, an important concept is the spectrum of CNS depression and death. So first of all, we will start with sedation, which is just relieving anxiety, relieving the overactivity of the brain, and then hypnosis, which is sleeping, and then anesthesia, and then coma, and lastly, you have death, which is not on this graph because we don't want to look at it. Like, what is the difference between sleeping and anesthesia? In sleep, if a patient is like in sleep, you can still feel pain. If I pinch a person hard enough while they're asleep, they're going to wake up. If a person is under anesthesia, they will not wake up. So it's a different kind of inhibition. طيب. These drugs all would fall somewhere in this graph. طيب. They're either drug A or drug B. That's a later discussion. My point is, all of these drugs depress the CNS enough that they will cause the sedation, hypnosis, anesthesia somewhere. So if it's linear, if they're all like kind of dose dependent, and it depends if it's linear or if it's saturation. If it's a linear, meaning more dose of the drug, more CNS, at some point my patient will die. And if it's saturation, my patient can never really die, but they can they can just be, at a critical stage. And this is important. We're going to talk about it here. These are all the drugs. You have benzodiazepines. You have non-benzodiazepine receptor agonists. Sorry, agonists. And I call them Z drugs as well. And you have also Z drugs. Zolpidem, zalplon, and esozopicon. And then you have ramultation, buspirone, barbiturates, and the antidote to all, or just the antidote, we're going to talk about it, just two actually, طيب. These are all my drugs. These are all my sedative and hypnotics. Let's jump into each. Starting with the GOAT, benzodiazepines. You hear it saying on TV shows, benzos, whatever, patient has anxiety, take a benzo. Okay, amazing. Like, what actually are benzodiazepines? We have a lot. Diazepam, prazepam. So in order to distinguish if I have a benzodiazepine, I will look for a zepam or a zolam. All right? So if I have a diazepam or an alprazolam, I'm talking about a benzo. Now, baclofen is a benzodiazepine, but it's like the exception to the case, and it's not mentioned. Important for you guys. Like, mode of actions of benzodiazepines. We mentioned this earlier in anesthetics. They are GABAergic agonists in some shape. And the way they work, they are indirect GABA A receptor agonists. So this is the GABA receptor, which is a chloride channel, and you have multiple isoforms, whether it's A2, A3, A5, A4, A6. Benzo would bind to A2, 3, and 5. Although somewhere in the transcription it also mentioned one, but for now let's stick to these three. Where does it bind? Over here. Where does GABA bind? Over here. So is it an actual agonist? It's an indirect agonist, meaning it would potentiate and enhance GABA-mediated inhibition. It will enhance the binding of GABA, and it will increase the chloride conductance, increasing the frequency of opening the chloride channels. I'm not actually opening the channel. I'm just increasing the chance of GABA binding will then cause hyperpolarization and inhibition of the AP. Tamam? So by doing so, we're just potentiating GABA. Pharmacokinetically, we have oral pills, IV, and they are a faster onset if it's lipophilic because of the potency. Diazepam and triazolam are my most rapid onset drugs. All of them go through hepatic glucuronidation metabolism. So it's important to consider a patient's liver condition, whether they have liver disease, alcohol, or whatever, because it can mess with drugs interactions. They have a long half-life because they can have active metabolites. So even after I metabolize diazepam in the liver, oh boy, I can have another metabolite still potentiating my GABA. Amazing. Now these facts, I'm not sure how important they are, but I wanted to mention them for creative. And lastly, it can cross the placenta. It can even go to the fetus and also depress or potentiate the GABA receptors there. Right? So benzodiazepines, all of these GABA receptor, and the way they work, and this is their structure. You have a diazepine ring and benzene ring, and this is more so pharmacological or whatever. It's not really another message. Their effects are as follows. We have sedation, which is anxiolytic at low dose. And I'm going to depress the effects on psychomotor and cognitive function. So a bit of euphoria, some impaired judgment, some loss of self-control, but they're also more sluggish, they're more so relaxed. This is sedation. That is at low dose, LD. And then if I increase the dose, a higher dose, I'm going to induce hypnosis. I'm going to decrease sleep latency, which is the time between me lying down trying to fall asleep and me actually falling asleep. And by decreasing so, I'm going to also just, increase stage 2 NREM and REM and so on. Basically, I'm just falling asleep faster. And the nice thing about benzodiazepines, there is no or minimal respiratory depression. However, if a patient has pulmonary problems such as COPD, they may develop respiratory depression, and also at a very higher dose. And there's no much effect anticipated on the cardiovascular effect. However, if a patient, heart failure or hypovolemia, and obviously if a patient is of extreme collapse, they're gonna collapse. What can you do here? Benzodiazepines, something nice about them, they have anticonvulsant effects, meaning they're anti-epileptic. And that's why they're the ghost. They're everywhere. They're in the anesthetic lecture. They're in the hypnotic lecture. They're in the anti-epileptic lecture. So they inhibit this form. What is a seizure ultimately? A seizure is just neurotoxicity. They're going to inhibit it by potentiating GABA receptors. Hence their anticonvulsant effects. And lastly, muscle relaxants because of their inhibiting effects on the neuromuscular junction. So these are the 4 effects of benzodiazepines. And now when we talk about the indications, these are any extras from me, so you know which one is for what. This was how it was given to us last year. For this year, it's much simpler for you. Just know the use for it. The most important thing about benzodiazepines, yes, they have a long half-life, but they're all for short-term usage. So you don't develop tolerance, so you don't develop dependence, and so on. Use them for their sedative effect and anxiety. And situation self-limiting anxiety, different levels of it. You can also use it for its hypnotic effect. They can also cause anterograde amnesia, meaning that when they're given and then a person falls asleep, they can forget that period of time. And they are also anticonvulsant, as we just said. We can use them to control withdrawals of alcohol and muscle muscular relaxants. Then basically all their effects are their indications again. As you can see, diazepam is the most important one. It will show up again in the anticonvulsant lecture. And atonia, muscle relaxants, you have back. But again, diazepam. Disorder and obstructive sleep apnea. Both of these was mentioned in your psychiatry lectures. In pharma, I also take facts from psychiatry. I take facts from pathology, from anatomy. I draw a full picture. This is neuro. Neuro is the most crossover, interconnected block. So please do this. Whenever you have a chance of cross-referencing and cross-linking, do that. So just keep these contraindications at the very back of your mind later on for the final. And their adverse effects are obviously, CNS depressants. And worst comes to worst, it can have, again, the CV and the respiratory depression. But again, if it's in a compromised patient, anterograde amnesia is not good because, yes, it's an indication for surgery, مثلا, if I need it. But لا سمح الله, evil people can use it to drug people and kidnap them, and for crime and so on. Because خلاص, you drink and you take it in, you don't remember, you fall asleep. I mean, they drug you essentially. And you can also obviously develop tolerance and dependence. And if you have any continuous dependence on it, you're going to obviously develop withdrawal syndromes. Now, withdrawal syndrome of benzodiazepine manifests in anxiety, insomnia, CNS excitability, convulsion, severity. And the severity varies. And you basically take all its effects and flip them over. And this is every withdrawal syndrome. Moving on. We're done from benzodiazepines. We know how they work. Now let's talk about none of these are purely hypnotics. They're not really sedatives. So they are used for sleep. Now they are indirect GABA A receptor agonists, meaning they work kind of similar where benzodiazepines work. Esozeplicon, the way they work is that they're a bit more selective than BZD, binding only at the A1 subunit as the most responsible for sedation hypnosis. There, they will induce the same effects and potentiate GABA. Again, increasing the chance of opening, not the duration. But then, when we talk about pharmacokinetics, zaleplon, all right, before pharmacokinetics, if we look at these names, we have the longest, this is how I memorized it, the longest one, and then ZA and ZO. طيب, ZAA is the first letter of the alphabet. It doesn't take a lot to say, so it's very short. It has the shortest half-life. And then zolpidem is the somewhere intermediate, and then esozeplicon, because it's the longest word, it has the longest half-life. Why is this important? Because when we're indicating it for a patient, I should understand which drug to give. Hello. When do we use these drugs? Again, they're more selective and they're only hypnotic, so I'm going to use them to induce sleep. I have a patient, they have insomnia. They can't really fall asleep. So in order to make them fall asleep, in order to induce sleep, I'm going to give them either Z drugs or esozeplicon. So a patient has trouble falling asleep, maybe give them a short-term zolpidem. If they wake up after 3 hours, I need a longer effect. Let me give them esozeplicon. If they feel, next morning drowsiness, and they don't wake up 3 hours later, they only feel this morning drowsiness, I can give them zaleplon, a shorter acting one. And because if it's more selectivity, it's preferred for the elderly. So why should I use these drugs? When compared, they have lesser side effects. They still have a risk for tolerance and anterograde amnesia. My patient is fully aware of what's going on until they fall asleep. It's beautiful. Now, let's say I overdose on either zolpidem or benzodiazepine, diazepam. This part of the receptor is being hypersaturated. I need an antagonist, a competitive antagonist. And here comes my savior, flumazenil. Remember when we mentioned this earlier on? Yes. It will bind to the benzodiazepine site, and it will block action of both benzodiazepines and my non-benzodiazepine receptor agonists. Now, a benzodiazepine overdose is managed in the following manner. I'm going to give flumazenol. I'm going to support their breathing, circulation. I'm going to remove their gastric content, alkalization, and hemodialysis. Just keep this in the back of your mind. Most importantly, just the drug you need to give. And you only can give this in IV. It has a short half-life, 1 hour long, so على طول you can relieve the symptoms. However, if a patient is dependent, it can precipitate withdrawal. All right, this is the rule of thumb. My patient is dependent on the drug. I flush out the drug, withdrawal immediately. So, to summarize, this is my GABA receptor. This is the benzodiazepine site, and this is where it will bind. Benzodiazepine. It's an indirect GABA A receptor agonist. It will just increase the chances of GABA binding, hence increasing the frequency of the GABA receptor activation. Then I have zolpidem binding at a different site, or sorry, it's a non-benzo, but just also binding at the same site, and doing the same effects. And then I have flumazenil, which is my antagonist binding at the benzodiazepine site. Right? Now, moving on to the rest of the drugs, we have buspirone, which is a very funny drug. It's a sedative, and we don't really know how it works. It has a high affinity for, serotonin A1A receptor and 2, and some affinity to dopamine 2 receptors, but we don't really understand how this has a way in, relieving anxiety or so. Yeah. Now, it's indicated for selective slow onset anxiety. So a patient with, general anxiety disorder or social anxiety, this is perfect for them. However, if my patient has acute panic attacks or acute anxiety, this can't work for them. Or if my patient is trying to fall asleep, this is a sedative. It's not a hypnotic. It's not going to work for them. So we don't know how it works. I don't know. So it has this kind of like thought bubble up here. And the way it's taken, it's by oral. It's, we can only really take it for, what am I saying? Sorry. All right. Once again, to recap, it needs time. So 3 to 4 weeks, and then it's going to have some kind of effect. So you need to still manage with the patient, follow up, and so on. Why do we give this drug? Because, again, there's no withdrawal symptoms. There's minimal abuse potential. It's very chill, and it's nice. There's no hypnotic effect. So elderly patients, they're safe. They're not more sensitive to this effect, right? Beautiful. Moving on to your dual orexin receptor antagonists, suvorexant and lamborexant. And in order to explain this drug, which is a hypnotic, meaning it is used to induce sleep, in order to explain it, we need to explain what orexin is. Orexin A and B are peptides in the body that promote and stabilize wakefulness with projections from the hypothalamus to the cortex. Okay, that's all you need to know. And they bind to orexin 1 and 2 receptors. So of them, 1 and 2, I'm going to prevent this stabilization of the wakefulness, or whatever you want to call it. I'm gonna hence make the patient fall asleep. Beautiful. So in the name, if you look carefully, orexin, orexant. Beautiful. So suvorexant, lamborexant are my dual, because they antagonize both receptors, orexin antagonists. That's as simple as it gets. You can take them orally. Lamborexant, the longer one, has a longer half-life. However, you only use this up to 4 weeks, not any longer. So back over here, buspirone, you need 3 to 4 weeks in order for the effect to be established, because it's a very slow onset anxiolytic agent. Here, you can only use these for 4 weeks, because then, khalas, no more effect. Orexin, which is a natural way to antagonize sleep, gets neutralized. Adverse effects, CNS depression, next day drowsiness, just keep using. And the reason I have hearts here, because apparently when, and this is a psychiatry fact, when you're in love with somebody, your body self sitting in bed can't fall asleep and you're in love or something. And that's how psychiatrists, figured this out. Where orexin, it's kind of a love compound that keeps you awake at night, hence the hearts. Now, ramultion is another way of antagonizing natural works. It antagonizes, or sorry, not antagonizes. It's an agonist to the melatonin receptor. So melatonin goes to the hypothalamic suprachiasmatic nucleus and it will promote sleep. That's all you need to know. Again, it reduces sleep latency, and by doing so, promotes sleep. It doesn't induce sleep. It's not like zolpidem. Very important distinction. So if my patient has difficulty falling asleep, they're drowsy, but they can't really fall asleep, I can give them ramultion. If my patient is insomniac and they can't really fall asleep at all, I'll give them Z drugs. All right, beautiful. And this is given orally, shorter half-life. You can take this indefinitely. Now, to the big bad of this lecture, barbiturates. Remember when we talked about thiopental earlier on? Now, both of them we're going to talk about. Both are sedative and hypnotic because both work at a level of the GABA receptor. They are an indirect and a direct GABA A receptor agonist. You can see it clearly over here. They don't bind where benzodiazepines bind. They bind somewhere else. By doing so, they can indirectly increase and potentiate GABA-mediated inhibition. And at a very high dose, they would directly activate GABA receptor. So this is very crazy stuff and very dangerous stuff. They're not like benzodiazepines. They only have an IV, what's it called, IV formulation. And they are a liver enzyme inducer. They just trouble everywhere, Salah, and they're very rarely used for this reason. And you can very rarely use thiopental for anesthesia, and you can very rarely use them for anxiety or to induce sleep because of their very crazy effects. However, they're very good for seizures, phenobarbital we'll be talking about later. And back to their pharmacokinetics, liver enzyme inducer. Thiopental has a liver metabolism. However, you need to understand that phenobarbital has like only excretion by it's only metabolite. Sorry, it's only excreted by the kidneys in the urine. Tamam? So if my patient has urine kidney problems, I can't really put them on phenobarbital. So again, anesthesia, thiopental, anti-epileptic, phenobarbital, and alcohol withdrawal syndrome, I can give them phenobarbital. This, we're going to talk about them later, the stratus epilepticus, but just keep in your mind from now, the foreshadowing is insane. When you're talking about adverse effects, the scariest one to mind is not sedation or nystagmus, it's respiratory depression, because it follows a linear dose increase. Meaning, if I take barbiturates indefinitely, I may die because it can cause death. It will indefinitely suppress my CNS because it can indefinitely, at high dose, open my GABA receptor. How crazy is that? CNS depression causing further respiratory depression, so it's dangerous. It has a very low margin of safety, and there's no antidote. See, flumazenil binds here. It doesn't bind here. I can't use flumazenil to antagonize barbiturates. This is important to understand. Halla. Lastly, obstructive sleep apnea would make this worse for the respiratory depression, so it's contraindicated in these patients. Again, this is a fact mentioned in psychiatry, just mention it to you from now, in your mind. And this is a summary for you. Again, if I need to induce sleep, I'm going to give these. If I have like anti-epileptic and other stuff, I can use benzodiazepine. If I have an overdose of benzo or Z drugs and azaziplicone, I can give flumazenil. Now, orexin antagonists, melatonin antagonist, bispirone is for selective slow onset anxiety, has a very long half-life, and barbiturates, they don't have an antidote. And if I want to promote sleep, I'm going to give ramultion, tamam? And flumazenil, my antidote. Easy peasy anti-epileptic drugs, easy. Sorry. Moving on to epilepsy, where we just talked about migraines. صح? The epilepsy are a different kind of story. Epilepsy is a chronic disease, and it can be caused by a lot of things. I'm pretty sure you covered them in your physiology lecture. It can be detected by EEG. Now, epilepsy is a chronic illness of seizures, but seizure can happen outside of epilepsy. Not every seizure is caused by epilepsy. Like if a person has a one-time seizure, I'm not gonna diagnose them with epilepsy. No, epilepsy is a continuous illness. It's a syndrome condition. So the way it works is I'm going to have this high frequency discharge of impulses by a group of neurons in the brain. Somewhere in the brain, it's just firing more than usual and it's just disrupting my brain waves. The way it works, I'm going to have unopposed excitation, where whether it's an increase in sodium and calcium currents, or an increase in glutamate and aspartate, or I'm going to have a decrease in my inhibitory pathways, whether it's decreased GABA activity, whatever, okay? Now, my anti-epileptic concept, or pharmacological concept, I need to restore balance to this epileptic brain. I need to dim down this excitation and increase this inhibition. تمام? So any of these drugs will either inhibit calcium and sodium or enhance chloride and GABA. Yeah, these are the drugs. But this is a very boring way to put this on. However, I just need to understand that you have so many drugs for epilepsy because they target different pathways. And the way I would go on to classify them is the following. GABA action, where we have benzo and barbiturates. We already talked about how they work. And we're going to add to them valproate. And then you have sodium channel blockers, 2 drugs, calcium channel blockers, 4 drugs, and then new drugs where they just work in different ways, multiple ways, sodium, calcium, and GABA all at the same time, chloride, whatever. And you can see gabapentin and pregabalin are both up and down. So they're new, but I would put them in calcium channel. Allah, this is for you. And this is all the drugs nicely summarized. But we got to go through all of them. But before that, beautiful introduction. Epilepsy is classified in the following, and we need to just focus on 2 things. Status epilepticus and where was it? Absent seizures. So when we talk about seizures, we can have a partial seizure, meaning you can have it either be simple or complex, where only it's only focused in the head, it's not really focused in the whole body. And a simple one won't really have loss of consciousness. However, a complex partial seizure, because it's complex, it can have loss of consciousness. And usually there's aura in there. Again, all of this is Sarah explained very well in your physiology lecture. I'm not going to really delve in deep here. But absent seizures are a kind of generalized seizure covering the whole brain, where it's common in children and it's very short. Tamam? It lasts more seconds, momentary loss of consciousness, patient freezes, they just phase out, then comes back. Tamam? That's your absent seizure. It's called petit mal. You also have a tonic, myoclonic, and infantile. But most important and dangerous is status epilepticus, meaning you have seizures so frequent, there's no recovery. I'm having seizure number 1, seizure number 2, 3, 4, 5, warabad, behind each other, nothing changes. No recovery in between whatsoever. And this is life-threatening. The brain is getting fried. Again, what is a seizure? It's just excitation, continuous neurotoxicity. It's dangerous. So play. How do we attack seizures? Anti-epileptics. We start with sodium channel blockers. Again, sodium current is excitatory. So when I block it, I'm going to decrease excitation. And we can start with phenytoin, the OG. The OG of all anti-epileptics. It's a sodium channel blocker. It stabilizes neuronal membranes to depolarization by, again, just blocking the gate and preventing influx of sodium. By doing so, I'm not going to further transmit signal, and also at a high concentration, I'm going to potentiate the effect of GABA. However, that is less to your concern and importance. It's just a side fact. Like, pharmacokinetics-wise, we have varied intestinal absorption, and also whenever we have absorption, we have a first order to zero order kind of pharmacokinetics. Whenever we have low dose of phenytoin, It's a perfect first order metabolism. Nothing goes wrong, right? However, when I have a high dose of phenytoin, my liver can't keep up. My liver is going to go into zero order, all right? It's going to accumulate this drug. It's not going to metabolize it. I'm going to have toxicity. I'm going to have horrible toxic effects. By doing so, this drug has a very narrow therapeutic index, meaning monitoring is needed when I'm on phenytoin. It's highly bound to albumin. تمام? Indicated in all epilepsy because it works on like it's a very broad spectrum. It works on everything except for absence seizures. Why? Absence seizures are targeted in a very specific channel. We're going to talk about that later. هلا, it's also indicated in trigeminal neuralgia, which is trigeminal pain general to the trigeminal nerve. It's insane. It's one of the worst kinds of pain you'll ever experience in your life. And these patients, يعني, they can get suicidal. It's so bad. So phenytoin could be given to them. It's a cardiac arrhythmic, anti-arrhythmic. Forget about this for now. Most importantly, we can use this to treat status epilepticus. My patient has seizures uninterrupted. Phenytoin could cure that. However, phenytoin has a lot of side effects, and they're annoying. And these side effects range from GI irritation, ataxia, diplopia, osteomalacia, and it increases androgen secretion, leading to two cases, hirsutism and gingival hyperplasia. You see here the gum, the gingivia. You see how like it's increasing in cells, the hyperplastic it is. This is a very, very common effect of phenytoin. تمام? And one more thing about phenytoin, it's teratogenic. It can cause megaloblastic anemia in the mother, meaning less folate goes into the kid, into the fetus, causing spina bifida. That is one way. And again, it can cause, or another way, it can cause something called fetal hydantoin syndrome. Hydantoin syndrome, which is a mental disorder, cleft lip, low set ears, nail hypoplegia. It's horrible. Allah, you never want this to be your kid's patients. Your patient's kid. All right. Now, certain drug-to-drug interactions into metabolism. This is keep it at the back of your brain. But you don't really give this with barbiturates, carbamazepine either, which is the other sodium channel blocker. But yeah, you give this alone. You don't give this to a pregnant lady, and you need to monitor it very carefully. You can give this to trigeminal neuralgia, status epilepticus, and it works by inhibiting sodium. Milh. Again, now a nice thing about, or something I want to do for the anti-epileptic section here, we need to keep track of the drugs we can treat status epilepticus with. So right over here, we start with phenytoin, our first drug. Moving on to carbamazepine, which is the second sodium channel blocker. Now, it works not the same as phenytoin, and pharmacokinetically also. For indications, however, it's also treating all epilepsy except absence seizures and trigeminal neuralgia, but we don't give this to status epilepticus. Adverse effects include sedation, ataxia. So again, if my patient is a truck driver with seizures, obviously we don't want them to have a seizure, but also I don't want them to feel sedated, so we don't give them. And it can be teratogenic because it again interferes with folic acid and also could cause hydantoin syndrome. So why do we give this drug? It's the same to phenytoin, but considerably safer. We don't have this increased androgen secretion. We don't have hirsutism. We don't have gingival hyperplasia. It's much safer, realistically, but still we don't give this to pregnant ladies. Please don't ever. Now we're done from sodium drugs. Let's talk about GABAergic drugs, starting with my goat, valproate. Goat number one, diazepam. Goat number two, valproate. طيب, valproate or valproic acid, sodium valproate, the way it works is very nice. It inhibits the GABA transaminase enzyme. Now, benzodiazepines and barbiturates would potentiate the receptor, Here, we are increasing GABA bioavailability. More GABA, more chance of GABA receptor activation, less epilepsy. All right. It can also block the voltage-dependent sodium channel. It can also decrease calcium currents, and it can also block glutamate and MDA receptors. So hold on a second. It has five mechanisms. It has what, four mechanisms? GABA, sodium, calcium, glutamate. It's the go. I'm telling you, go. Play it. Indications, all epilepsy. No joke, everything. Even absence seizures. Why? Because the T-type calcium channels are targeted. This is why absence seizures happen. All right, it's this kind of calcium current. طب ممتاز. I can target also generalized tonic-clonic seizures, bipolar disorder as well. Beautiful. Now, adverse effects, however, it's teratogenic, so I can't really give this to a pregnant lady. It's not completely the go, but still, good enough. GIT symptoms, it can cause hair loss, alopecia, keep this in mind. And very, very rarely it's hepatotoxic enough to cause fulminant hepatic failure. Fulminant means rapid hepatic failure, all right? Moving on, diazepam, lorazepam. By this point, you guys should tell what these are. Your diazepines, benzodiazepines. And we're not even gonna talk about how they work, but we can give these to all epilepsy, including, actually, I'm not sure if it's absence seizure as well, so I'm not gonna say it. It's just all epilepsy, it's not absence seizure. And most importantly, status epilepticus, phenobarbital as well. All right, we're not talking about thiopental, phenobarbital. All right, please. Thiopental is the anesthetic. Phenobarbital is my anti-epileptic. طيب? And the most important distinction, frequency of opening increasing is benzodiazepines, and duration of opening increasing is phenobarbital. Again, keep in mind how this is a dangerous drug that we shouldn't really give often. And it can also be used to treat status epilepticus, neonatal seizures as well, and so on. So, or before that, we also have Salaha, this newer drug, which kind of works the same here, Taja. Whatever, I just mentioned it for completion's sake because on the slides, the doctor just I'll skip. So, I can add two more drugs now, right? I can add diazepam, sorry, three actually, lorazepam and phenobarbital. Beautiful, beautiful, beautiful. Hello. Let's also add absence seizure drugs, valproate, correct? Now, you guys can third guess what the last one here will be, but Salah, it's very easy to guess. We are done from GABA and we are done from sodium. Let's talk about calcium channel blockers. Calcium channel blockers, we have four drugs more or less. Starting with ethosuximide, which is a T-type calcium channel blocker. And because it's a T-type calcium channel blocker, it can be given to absence seizures, petite mal seizures, and it's safe for children. T-type calcium channel are like they play the role in the spike and wave 3 hertz discharge of the absence seizures in the thalamus. So anytime we see it, we think absence seizure. Tamam? Gabapentin, we don't really know how it works. Yes, it has GABA in the name, but it doesn't really work on GABA. However, it decreases calcium entry and it decreases glutamate release. So I think it's worthy to put with calcium channel working, like drugs. We can give this as migraine prophylaxis. Remember gabapentin, the one I told you it was not mentioned in the lecture? So now, how many migraine prophylaxis can you guys name? Let's see how many I can name. Propranolol, gabapentin, venlafaxine, amitriptyline, lifestyle modifications. I don't care, I'm going to say that. If I'm not mistaken, thiopental. Yeah. I hope I'm not mistaken because that would be just embarrassing. But yeah, know your migraine prophylactic. Now, something that we give gabapentin to, besides seizures and partial seizures, we can give it to post-herpetic neuralgia, which is after your herpes, shingles, whatever infection. But we can give this most important to chronic pain and neuropathic pain. Do you guys remember that opioids cannot be given to neuropathic and chronic pain? Like, the patient has neuropathic pain. Poor him. What should I give him? Yalla, gabapentin. And I can also give him pregabalin because it's the next one. Now, pregabalin could be also mentioned in the GABA ones, but still, let's put it here with the calcium channel blockers because it decreases neuronal calcium channel currents by binding with the voltage gated channel, decreasing calcium and decreasing automated release. And also it increases GABA. Again, GABA is in the name, pregabalin. However, gabapentin is a fraud. Like levetiracetam, it's a newer drug, and it's a crazy drug because the way it works, it binds to a protein which is called CF2, CV2A. It's a synaptic vesicle glycoprotein that would just small, allow for the exocytosis of neurotransmitter. However, it inhibits this presynaptic calcium channel, and by doing so, no exocytosis, no neurotransmitter release, and it acts as a neuromodulator, impeding the impulse conduction. Adverse effects, it can cause somnolescence, which is you trying to fall asleep, headache, some dizziness, and it's a lot of very irrelevant side effects. But its indications is important. Is it's pregnancy safe? Finally, something I can give to a pregnant lady. And also, it's indicated for status epilepticus. So, this is really great now. Calcium channel blockers. I can think of four things off of my mind. Ethosuximide working on my T-type calcium channels, so I can immediately think absence seizures, similar to valproate, where it works on the T-type calcium channel. And then I can think of gabapentin and pregabalin. Both have GABA in their name. However, the pregabalin is the only one where it increases GABA. Gabapentin decreases calcium. Gabapentin is migraine prophylaxis. Gabapentin and pregabalin are both for neuropathic pain. And lastly, levetiracetam, very fancy name, very long name, SV2A. It's such a nice, cool name, levetiracetam, SV2A. All right, there's a V in the name and the V in the protein. And it works on pregnancy and status epilepticus. There's your beautiful, beautiful recap. But more importantly now, let's add to our list, ladies and gentlemen. Status epilepticus, phenytoin, sodium channel, diazepam, lorazepam, benzodiazepine GABA, phenobarbital, barbiturate GABA, levetiracetam, SV2A protein. All right, beautiful. All of these are for status epilepticus. Absence seizures, valproate, sodium channel blocker, and a billion. Wait, what did I say? I am so sorry. Valproate, GABA, transaminase inhibitor, and also sodium channel blocker, and also T-type calcium, and also an MDA antagonist. So I was not wrong. Ethosuximide, T-type channel blocker. Beautiful. Tayyib. Third box. You guessed it, pregnancy. Things I can give to a pregnant lady. Levetiracetam. However, it's not my first line. I'm going to talk about my first line right now. Lamotrigine. These are your newer drugs where you can't really put them anywhere. So, khalas, let's just talk through them and we're done. And I was wrong. It's topiramate, not thiopental. Now, this is embarrassing. Like, for migraine prophylaxis, if you were not following this, whatever. Like, lamotrigine, felbamate, topiramate. Zonisamide, forget about it for now. Let's just talk about these three. Lamotrigine is very important because now the way it works is combined. It blocks sodium and also some calcium channel blockers. It's a very broad spectrum anti-epileptic drug, so I can give it to a lot of things, including absence seizures. Beautiful, partial seizures, generalized, and even bipolar disorder. Do you remember what I used to give for bipolar? Valproate. For a mood modifier instead of lithium. صح? I can also give lamotrigine. And most importantly, I give it to a pregnant lady. And this is my first line. طيب? It can cause sleepiness, diplopia, ataxia. I don't care about these as much as I care about giving it to pregnant ladies and absence seizures. Felbamate, important drug, it is indicated for drug-resistant epilepsy, which is not mentioned, weirdly enough, but it's an important distinction for you to know from last year. Let's say my patient has, generalized tonic-clonic epilepsy. I put them on valproate, like a very powerful drug. It didn't work. Lamotrigine, it didn't work. Let's try fulminate. It works. How? It blocks dependent sodium channels, NMDA, and it potentiates GABA. Whatever it does, it works. And that is important to know. Topiramate, it blocks sodium channels at high frequency, increases GABA opening. Most importantly, it just is a migraine prophylaxis. Again, let's name my migraine prophylaxis right now. Gabapentin, topiramate are my anti-epileptics. Venlafaxine is my SSRI. No, it's my SNRI. And then I have my TCA, amitriptyline, and I have my propranolol and metoprolol, my beta blockers, and lastly, I have CGRP antagonists. I did not forget about these, and lifestyle modifications. Now, last drug, similar to that weird GABAergic drug that I don't even remember, zonisamide. And you just keep it at the back of your mind. It blocks voltage, blah, 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 enhances. So it's just a combination. Okay, sodium, calcium, T-type. So maybe I can give it to absence, but it wasn't elaborated on. Doctor just skipped it. I don't care. But what I do care about now is my finalized list. So status epilepticus, these five, no more, صح? Phenytoin, sodium, diazepam, lorazepam, and phenobarbital, GABA. Levetiracetam is my SV2A. Guys, remember, SV2A. However, I give these, I give these to a patient going through status epilepticus. It's life-threatening, صح? If that doesn't work, worst comes to work, I'll put them on anesthesia, propofol. Worst comes to worst, general anesthesia, خلاص, get it into their system, induction, maintenance, and recovery. Oops. Sorry about that. Moving on to absence seizures, صراحة, we can just add on to the list lamotrigine. Can I add zenosulamide if that's how it's mentioned? I'm not really sure. Forget about it for now. Valproate, but go. Ethosuximide, L-type, T-type, and lamotrigine. Lamotrigine. I wrote it wrong, but yeah. Lastly, my pregnancy, lamotrigine. I wrote it wrong here as well. Levetiracetam. And something important to mention for pregnancy is that they should start folic acid 2 months before conception. And what do we mean by this? Let's say a lady has epilepsy, خلاص, she's diagnosed, she has continuous seizures. So I'm gonna give her before, like she wants to have kids with her husband. I'm gonna put her on folic acid 2 months, preferably, as they're trying to conceive, and consistently throughout their pregnancy. Keep this in your mind, it's very important. The summary is for you, it's not for me. And I did write trigene wrong, forgive me. I've been working on this for so long, it shouldn't have taken this long. More stuff for you guys. These are my own notes, which you could scan on the first slide. Again, status epilepticus. This is how I had to make sense of things, to classify, organize, reorganize, and so on. But most important thing, we covered this for you guys. The prophylactic, we covered it for you guys, and the drug lowering seizure threshold. These are certain drugs that are mentioned in, I think, your psychiatry lectures mostly. But however, they lower the threshold for a seizure. So if a patient is put on bupropion, whatever I said, these patients are more susceptible for a seizure. An epileptic patient should understand if they're put on this drug, they have higher chance of developing a seizure. Tricyclic antidepressants, methylphenidate, antipsychotics, all of these lower the threshold of a seizure. When you study all these lectures, everything comes nicely, everything comes together. Beautiful. A neonatal seizure, we give them phenobarbital. An infantile seizure, we give them valproate. And these are the pregnancy safe. This is from our slide last year. I think this year none of this was really emphasized on you guys. And khalas, forget about these for the most part. But the most important one is the absence seizures. What do you give and what do you not give? And valproate is very high and good, but teratogenic, don't forget. It's not safe. Final lecture. It's 4 a.m. Yellow still. I hope guys are actually benefiting from this. You're not. Yeah, at least you can guys study from the slides. It has everything in it. Put it on 2 times speed, anything, and for your final. You guys know better what to do. Like degenerative diseases. This lecture is very fun and easy. When we talk about degenerative brain diseases, we have Parkinson's and Alzheimer's. Both of these diseases eat away at the brain, slowly causing ex-hydrocephalus. صح؟ حلو. How they work? Parkinson's, pathophysiology briefly, cell loss at the nigrostriatal projections, decreased activity of dopaminergic neurons and subsection nigra and striatum, increased acetylcholine activity. Clinically, you diagnose by tremors, muscular rigidity, bradykinesia. This is the triad, صح? Cogwheel, lead pipe, rigidity, all this, blah, blah, blah. Hello. Treatment strategy for Parkinson's. So we know that there is less dopamine activity and more acetylcholine activity. So let's just get the balance back. It's like the seizure. Let's just reverse stuff. So increase dopamine, decrease acetylcholine. How do you do this? You can either give dopamine, a precursor of it. You can either give an agonist, an analog. You can increase the release of endogenous dopamine, which is such a cute concept. It's like making someone happy because that's dopamine release as well. So it's a very cute concept. And you can decrease metabolism of dopamine. So I think I'm losing it. So let's just focus and lock and play. And for decreasing acetylcholine activity, obviously antimuscarinics. You guys remember this from your POD. And the most important thing to note here, the most important dopamine receptor at play here is D2. You have D1, D2, focus on D2. حلو. Alzheimer's, the second disease. Again, briefly, mutations in APP, Y secretase, blah, 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 amyloid, list inflammatory, tau hyperphosphorylase, you have tau NFTs, decreased acetylcholine activity, and you have neurotoxicity. So, clinically, they have dementia, cognitive function loss, and the treatment strategy of this would be increasing acetylcholine activity through acetylcholine esterase inhibitors. Again, remember your POD, and decreasing processes that lead to neurotoxicity. You have one drug, an MDA antagonist. So cute. We're gonna talk about it. I don't know why I'm saying cute to drugs, but yeah. Allah. Dopamine receptors and muscarinic receptors, because this is the fundamental of this lecture. This is all for your info. But in order to further understand pharma and صراحة second guess MCQs sometimes because you forget every detail, you can just know where those receptors are found and their effects and eliminate stuff. طيب, dopamine receptors are found in a lot of areas in the brain: pituitary gland, heart, kidney, adrenal gland, GI, pancreas, immune cells even. And the effects of dopamine, it can cause vomiting and nausea and area postrema of the chemo trigger zone. In the cardiovascular, it has an interesting effect where in low dose, it can cause vasodilation and decreasing blood pressure and increasing heart rate and contractility. And in a higher dose, vasoconstriction and increasing blood pressure. In renal, it's going to vasodilate, increasing the urination. In GI, decreasing motility, meaning constipation. Beautiful. Muscarinic receptors are in the eye, heart, lungs, blood vessels, GI, bladder, exocrine glands, CNS. And what do they do? You guys know this. Cholinergic effects. Come on, I don't need to say this. Neosis, accommodation, decreasing heart rate, AV conduction, decreased contractility, easy stuff. Bronchoconstriction, horrible for asthmatics. Vasodilation, decreasing blood pressure, increasing GI motility, diarrhea, and bladder contraction, urination, salivation, lacrimation, sweating. Beautiful stuff. These are my own notes. I'm not flexing, just here for your own صراحة reference. This is pathology, Parkinson's, what is this? The diagnosis, pathophysiology, clinical, pictures. I think this is Lewy body of the what's it called? Yeah, the striatum pathways. I think the direct and indirect pathways over here. Alzheimer's, same story. Let's move on. So for this part of the lecture, we're gonna have over here how we which kind of way we're fixing the drug. So fixing the disease. So here we have Parkinson's disease administration of dopamine. Beautiful stuff. Like, keep an eye on there. So dopamine, يعني the main way to fix Parkinson's disease is to give the dopamine precursor, which is levodopa. All right, L-dopa. And this is the first and only, يعني صراحة it's the first line treatment, and no other treatment could work alone except adjunct to levodopa. All right, keep this in mind because it's very important. So how does levodopa work? Again, dopamine, this is the precursor, and it becomes dopamine by dopa decarboxylase. And then once dopamine is in the brain, it can work and can be even further into norepinephrine, epinephrine, tyrosine. This is all biochem, mole stuff. We don't care about this. However, levodopa is a precursor that can cross the blood-brain barrier. Why don't we just give dopamine? It cannot cross the blood-brain barrier. That's the whole point. So we give the precursor, which can cross the blood-brain barrier. Like, however, if it goes, and if I administer levodopa to my body, dopa decarboxylase is also in my peripheral system, in my GI tract, in my blood as well, whatever. If I administer levodopa alone, only a small percentage will get to the brain. However, if I give a dopa decarboxylase inhibitor, which is my carbidopa, then it will inhibit it peripherally, and more levodopa will get to the brain. طيب, what happens then? خلاص, my levodopa is in the brain, but carbidopa is also going to inhibit it, صح? Because it's a dopa decarboxylase inhibitor. No, carbidopa cannot cross the blood-brain barrier. So it's the perfect transit, it's the perfect commute. Take levodopa and carbidopa. Levodopa goes to the brain. Carbidopa cannot go to the brain. Levodopa does not get decarboxylated outside the brain. Perfect love story. طيب. And this is the whole idea here. And by so we're increasing dopamine activity in the brain. So effects, it's going to treat immediately the bradykinesia and rigidity more than the tremor. However, you're going to develop gradual tolerance to the beneficial and adverse effects. So let's say over the time, you're going to need more and more doses of the same drug to treat the bradykinesia and rigidity. So it's the most effective in the first 2 to 5 years of treatment, because unfortunately, when you talk about Parkinson's, by the time you have the symptoms, by the time you have the bradykinesia, the tremor, and so on, the patient have lost 50 to 60 of the neurons, dopaminergic neurons of the nigrus, of the striatum. So it's only beneficial for this period of time, but it's still very therapeutic. Now, pharmacokinetic wise, it's rapidly absorbed. However, the stomach must be empty, because otherwise the ingestions of meals will interfere with the carbidopa activity and the absorption and so on, and it's not going to be as effective. And it has a very short half-life. So خلاص, once it gets to the brain, it immediately gets metabolized to dopamine, and great stuff. Adverse effects, because it's not perfect. It's not a perfect system. Some dopamine will be peripherally decarboxylated, and it will go to the area posterema, causing you nausea, vomiting. However, this decreases a lot with carbidopa. Some postural hypotension, because in low dose, if you guys remember, dopamine causes vasodilation. Some tachycardia, we know why. Involuntary movements, restlessness, psychological disturbance, that doesn't care. However, what's important is suppression of prolactin. All right, keep this in mind. Why? We'll come to it later. Like, drug-to-drug interactions is important for levodopa and carbidopa because 3 things matter here. Vitamin B6, because we're talking about decarboxylase, where increasing peripheral metabolism of levodopa would decrease its effectiveness. Monoamine oxidase inhibitors, because they're going to decrease the metabolism of dopamine, causing, if you are taking both with levodopa, you're going to have excess dopamine, and you're going to have a hypertensive crisis. And antipsychotics, metoclopramide, because they're going to inhibit. They are both mainly working to blockade dopamine 1 receptors, which will exacerbate motor dysfunction. And they're going to be a counterintuitive effect. And you're trying to increase dopamine, and these drugs are trying to decrease dopamine somewhere else. So they're going to collide with each other. Now, an important concept with carbidopa and levodopa is two phenomenons, on and off phenomenon and wearing off phenomenon. Now, this dopamine is not made in the body. It's artificially induced, صح? Artificially brought in. So because of this, it's fluctuating inside the body. It's not a nice curve. And because of that, we can have fluctuations in motor control and dyskinesia. And this is the on and off phenomenon, meaning throughout the period, and you have Parkinson's disease, صح? You have the symptoms of Parkinson's disease. My patient has tremor, bradycardia, and so on. I give them levodopa. Sometimes they're perfect. Their on symptoms are great. They don't feel the Parkinson's disease. And sometimes they have off symptoms where they do feel Parkinson's disease again, but they're on the drug. And there's fluctuating, it's unpredictable, it's sudden changes. And at some point they don't have bradykinesia, another point they do. They don't feel rigid, another point they do. It's fluctuating on, it's unpredictable. This is the on and off phenomenon. Why? Because it's fluctuating on physiological brain concentration. Now, the wearing off phenomenon, it's just when the drug dose, and you give a patient, what's it called? You give a patient like a pill of levodopa, and they're waiting for their next dose, and slowly, like halas, tapering out. This patient's symptoms would come back naturally. It's expected. There's a gradual return of tremor, stiffness, and slowness, and it's predictable. This is calling the wearing off phenomenon because it's wearing off of the drug until they take the next dose. How? Managing both, okay? Because again, dopamine, like levodopa, has a very short half-life, and it's caused by this fluctuating pattern. On and off phenomena is unpredictable, wearing off is predictable. Both, صراحة, can be managed by not taking the oral route, instead taking sustained release subcutaneous drugs with the levodopa and carbidopa. Which brings us to pro-DOA-DOPA. Now, pro-DOA-DOPA is given to advanced Parkinson's disease, and it's basically just a subcutaneous infusion formulation. There was a picture I forgot to add where a patient had a device connected to their body, and this was pro-DOA-DOPA composed out of phos-levodopa and phos-carbidopa. So I have a patient, they have severe motor fluctuations, they have on and off phenomenon and wearing off phenomenon, and they're taking normal levodopa, carbidopa. I can give them pro-DOA-DOPA, phos-levodopa, phos-carbidopa, and their symptoms would be more increased. They would be more relieved, and they're more consistent to the treatment because it's continuous, sustained release. This was a question that came in the final. I didn't get it right. Keep it in your mind. Don't forget these drugs. Thank you. Allah, we're done from the first type. So, moving on to the activating dopamine receptors. So we're talking about dopamine agonists. You have bromocriptine, pramipexole, and ropinirole. These are the most important ones, and also apomorphine. Hello. All of these work at varying levels of receptors. We mentioned that the D2 receptor is the most important one for Parkinson's. So pramipexole and ropinirole are your go-to here, as well as bromocriptine. They're all taken orally, and they have a longer duration, or like any duration of action than levodopa. However, adverse effects, because you're giving dopamine agonists, you're activating dopamine receptors. Again, let's remember what dopamine does. Nausea, vomiting, okay? And if you have that, you can give them, and if it's very extreme, they're taking these drugs and it's extreme nausea, vomiting, you can give them a peripheral dopamine receptor antagonist, an antagonist that does not cross the blood-brain barrier, called domperidone. So we give domperidone to just alleviate a bit about the nausea, vomiting. You're gonna have headache, drowsiness, psychosis, and just folly. Confusion, orthostatic hypotension, we know why. Cardiac arrhythmias, we know why. All of the cardiovascular disease, like low dose and high dose effects of dopamine, easy stuff. Bromocriptine takes it a step further, where we can use it not only to treat Parkinson's, but also to treat hyperprolactinemia. Now, hyperprolactinemia, let's think. Why do I have hyperprolactinemia? Maybe I have a prolactinoma. I have so much prolactin in my body. My male will develop gynecomastia, will develop impotence. My females will develop menstrual abnormalities, anovulation, infertility. I can treat this with bromocriptine. Hello, apomorphine. It's another dopamine agonist. I know it says morphine in the name, but it's not an opioid. It's a, what's it called? It's like a derivative of morphine, but it's not an opioid at all. It does not work on opioids receptors. It works, however, on both D1 and D2 receptors because it's a non-selective dopamine agonist. It's also a serotonin A adrenergic receptor agonist, and it's a potent emetic. تخيل, it's an emetic. It's not an anti-emetic, it's an emetic. And oh my God, Apple just took 40 hours from me. So it's an emetic because these dopamine would go and trigger the area posterema, okay? Pharmacokinetically, it's a morphine decomposition product. It's not morphine, it has a short half-life, subcutaneous is the most effective. However, because of its potent emetic properties, we give it with domperidone because I want this apomorphine to go to my brain. I don't want it to go peripherally and into area posterior. حلو. طيب. All of these, guys, all of these drugs, we give them their adjunct. Levodopa, carbidopa is my main treatment. Prododopa, كمان is a main treatment. These drugs, adjunct. Apomorphine is also like an indication of it. It's adjunct for off periods. Remember the off phenomenon, the on and off periods? On is when my drug is working, off is when my symptoms are back. So whenever I have my symptoms coming back, I can give them apomorphine. And this emetic guy, he's going through it. That's why he's here. I love this drug. This drug is my favorite drug. It's amantadine. It's so cute. It stimulates endogenous dopamine release. It's just there to make everyone happy and just stimulate more dopamine cells into secreting dopamine. We don't know how it works. It just does what it does. It inhibits reuptake of dopamine. Like, what more do we want? It blocks cholinergic as well, which is another thing we need to do with decreased cholinergic activity, and MDA receptor. Beautiful. However, it's an antiviral drug, meaning it's not even meant to treat Parkinson's. It's meant to treat some virus, and it was given to Parkinson's patients, and subhanAllah, it worked somehow. So that's why there's a potato here, a very cute one, because it's a lovely drug over a virus downstairs. Again, adjuvant therapy, you never give us alone. Adverse effects, however, it's nightmares, which is not very nice. Insomnia, dizziness, hallucinations, retention of urine, peripheral edema, and just general stuff. And all of these are صراحة the anti-cholinergic like effects. Dry mouth, joy upset, peripheral edema, retention of urine. Like, think with me, all right, guys? Now we get to the bulk of this صراحة. We passed the bulk, but there's another bulk of this lecture. Now, onto the final dopamine kind of maintenance. It's dopamine metabolism. Now, dopamine is metabolized by monoamide oxidase and COMT. The monoamide oxidase, we have A and B. A being peripherally, B being CNS. Now, A, all right, breaks down norepinephrine, serotonin, dopamine, and thiamine. Monoamine B will break down phenylethylamine, benzylamine, dopamine, and tyramine. Amazing, beautiful stuff. هلا, we have inhibitors for monoamine A and inhibitors for monoamine B. Monoamine A inhibitors such as macrolopamide, biflotaxamine, bromophenamine. There should be an F here, but forget about it. These drugs, they're antidepressants. Okay? They're antidepressants. They increase your norepinephrine, your serotonin, because all of this metabolism is prevented. All of these will increase. However, because we're increasing norepinephrine and serotonin, there is a chance for hypertensive crisis and serotonin syndrome. These are very serious conditions. That's why even for antidepressants, these are the last line when everything else fails. So this is not our focus. Forget about it. I wanted to mention it here. So forward, it makes sense. I believe you took the lecture. Tell us. Well, I mean, B inhibitors are focused. Psilocybin, racegiline, the gelenes, okay? So they're gonna inhibit and I have bolded it out here. They were gonna inhibit the metabolism of these things, dopamine and tyramine, and yeah, monoamine B is in the CNS as well. So we're hitting two birds in one stone. Beautiful. COMT inhibitors such as tolcapone and entacapone, they sound Salah Spanish, so God knows. They are drugs for a basic Parkinson's. And something to understand here is that like the methylation of levodopa by COMT is minor. Usually you don't really have a need to use these drugs. However, when you have carbidopa, where you have an increase in bioavailability of levodopa, then this pathway becomes major and you need to actually prevent it. You get me? So usually levodopa doesn't reach a level high enough to be converted into 3-OMD. But when carbidopa is introduced and now I have a high amount of levodopa, more of it will be funneled into 3-OMD, and 3-OMD like actively competes with levodopa, which is bad stuff. That's why we gotta inhibit it. All right. يلا study monoamine B inhibitors, the gelenes. Guys, come on, it's easy. I just memorize it. The gelenes, they are selective and irreversible inhibitors of monoamine oxidase B. So by doing so, this is monoamine oxidase B over here, and it's not going to break down my dopamine, tamam? My DAT, or sorry, whatever, my dopamine uptake transporter is going to bring it in, and this is a mitochondria. It's not going to break it apart over here. It's just instead going to funnel it back, which is beautiful. I'm going to have increase in dopamine levels and decreased degradation of dopamine. And by doing so also, monoamine B also forms free radicals. These free radicals could go on and transform MPTP, sorry, I wrote that wrong, MPTP into MPP plus radical, which Saraha goes on and like further disrupt the neuron and hurts by oxidative stress and so on. So we're killing two birds in one stone. I'm increasing dopamine and decreasing radicals, whether it's superoxidase dismutase or actual the MPTP. Now again, this is adjuvant therapy. I can't treat Parkinson's with this alone, and it can allow a dose reduction of levodopa up to 30%. So it's beautiful. It's amazing. I don't have to depend as much on levodopa and all the adverse effects of levodopa and carbidopa. Halas, perfect. Let's just adjuvant it with this. Obviously more cost, but keep this in mind. Adverse effects, agitation, nausea, most importantly, serotonin syndrome could still happen. How? Ask. Tamam? And tyramine reaction as well. If a patient eats a lot of cheese and that cheese has tyramine in it, monoamine B inhibitors or A صراحة, any of them, tyramine reaction, hypertensive, mimics hypertensive crisis, and so on. Moving on to COMT inhibitors, tolcapone and entacapone, the Spaniards, they would inhibit COMT. By doing so, I'm not going into the 3-OMD pathway. And I'm going to increase bioavailability of levodopa and have it be transformed into dopamine by dopa decarboxylase in the brain. Beautiful. Wait, both drugs, tolcapone and entacapone, work differently. Tolcapone works centrally and less so peripherally. Centrally, it will inhibit it and it will smooth out the wearing off effects. Remember wearing off? Where the dose decrease, between خلاص, the drug is wearing off and you're waiting for your next dose, the symptoms come back, it will smoothen it out. It's not going to be as extreme. Now, peripherally, it will allow increased levodopa to cross the BBB by inhibiting through. Entacapone works peripherally and works exactly the same as tolcapone peripherally. It's going to increase the duration of dopamine. Both will increase the duration of dopamine action, meaning that will also be beneficial for what? My on and off phenomenon. هلا, in my on time where I don't have any symptoms, I'm going to increase the time of actual levodopa working in the brain. I'm going to decrease the off time where my levodopa fluctuates and it's not really there. Does that make sense? I hope so. Again, adjuvant therapy, I'm never gonna use this alone. It's not enough. It works by supporting levodopa. Everything does. So it's adjuvant therapy. It's for wearing off symptoms. Adverse effects, hepatotoxicity for tolcapone. So generally, entacapone is safer, and entacapone works peripherally, and this drug really just works peripherally. Dyskinesia because you have effective brain levodopa, and diarrhea. تمام. Now, moving on to muscarinic antagonists. هلا, we are done from dopamine approaches. Let's look at the acetylcholine approach, which is a anti-muscarinic approach. We're going to block central muscarinic receptors. Mainly, it's benzotropine. Gotta know here. If you guys remember this from your POD lecture, you're going to decrease dopamine in the striatum also by blocking the central muscarinic receptors. It's going to decrease dopamine in the striatum, augmenting. All right. Basically, when dopamine decreases, it augments the cholinergic system. When it augments the cholinergic symptoms, you have this like increased acetylcholine activity in the Parkinson's disease. So by doing so, blockading this excess, you're targeting this kind of cross pathway. Again, adjuvant therapy, you're never going to use this alone. And it's helpful in Parkinsonian tremor. Again, if you guys remember at the very start, when we were talking about levodopa, yes, it treats bradykinesia and rigidity. However, the tremor, you gotta give an anti-muscarinic agent for that. And our muscarinic agent is benzotropine. Slight improvement in bradykinesia, lesser extent in rigidity. So yeah, and Parkinsonism is caused by antipsychotic drugs. We're going to talk about this in a second. However, anti-cholinergic, come on guys, adverse effects. فكروا معي شوي. Dry mouth, alcohol, blurred vision, precipitation of glaucoma, urinary retention, constipation, easy stuff. So you never use this in glaucoma, you never use this in prostatic hypertrophy because of the urinary retention. Beautiful stuff and easy stuff. Now, drug-induced Parkinsonism is a case of tremor or Parkinson-like symptoms often caused by neuroleptics. Neuroleptics or antipsychotics, whether typical or atypical, and they mainly target the dopamine receptor. تمام؟ هلا anti-emetics also target your dopamine receptors, but not to the extent like centrally, صح? So neuroleptics and antipsychotics in a small number of people would have these symptoms. And if you just remove this drug, all these symptoms would be reversed to an extent. However, some things could never be fixed. For example, if a patient ever develops tardive dyskinesia from neuroleptics, that could not be reverted. It's irreversible. It's not cured by any muscarinic antagonists. And the only thing that I know works for that is Botox, which is insane to me. Tardive dyskinesia is just those small spasms of the eye, twitching of the eyebrow, the lip. It's really sad stuff. And with this, we finish Parkinson's. We move on to Alzheimer. I think it's a very straightforward process here. We're going to increase acetylcholine or we're going to decrease neurotoxicity, explained here. And might go donepezil, again, acetylcholine esterase inhibitor from your POD lecture. It's what works for Alzheimer's. You also have rivastigmine, galantamine. However, donepezil is the most important one. From POD, what do you guys remember from POD? Realistically, propranolol, benzotropine, donepezil. You guys remember these three? So I'm very proud of you guys. How do they work? They're gonna inhibit acetylcholine esterase. By doing so, they're gonna inhibit the metabolism of acetylcholine, increasing the bioavailability of acetylcholine in the synaptic cleft, enhance cholinergic analgesia, blah blah blah. Indication: mild to moderate Alzheimer. يعني صراحة, they're not gonna cure anything. They're just gonna help with the symptoms. And in very severe diseases, you're gonna give them as patches, long sustained releases. Adverse effects, think with me guys, cholinergic effects. So overload, GI, you're gonna have nausea, vomiting, diarrhea, cramping maybe. You're gonna have bradycardia. You're gonna have bronchoconstriction, tamam. So you're going to use them in caution in patients with asthma and COPD because of these cholinergic activity, increased cholinergic activity. And lastly, the cutest drug of all time, up there with amantadine, memantine. Now, this is not an antiviral as well, but the way it works, it acts by blocking overexcited glutamate receptors, like blocking entry of calcium, decreasing glutamate release, inhibiting processes which lead to neurotoxicity. By so, we're going to decrease the exacerbation of Alzheimer's, but it also maintains the activation of the receptors required for learning and memory in the brain. So it doesn't really affect that. Adverse effects, mild, reversible headache. With this is the last summary you guys get for Parkinson's disease. We get back to my approach to pharmacology. صراحة guys, يعني just again, I hope I made sense with everything I was saying. I hope I didn't make any mistakes. Right now it's 4:30 a.m. This path has been long overdue. It's all on me. It's my fault. Anyways, my approach, the way I study pharma, memorize these drug names. Don't mix them up. If you use mnemonics, Anki, anything, just understand. Try to understand as much as possible pharma. Pharma is really fun. Pharma is a lot of free marks. You don't have weird pharma questions. It's either you know or you don't know. It's either you remember it or you don't remember it, or you second guess it, or you understand the physiology of the body enough to second guess side effects or to choose the correct drug for the comorbidity. Keep in mind these stuff. Look at previous questions. Build this mental map. Write it down. Draw it out. Whatever you want. Understand the pathophysiology. Understand the essentials, because later on in your third year, this is how pharma works. You're not in POD anymore. It's not just brew memorization. You're not in MSI anymore. No, you are now taking these drugs. You are using the weapons of a doctor. You are thinking as a clinician right now. All right? And there's no perfect patient. You will have the responsibility to give these patients the drugs they deserve, inshallah, one day. So understand these drugs. Don't just blatantly memorize them. Correlate them to your lectures, correlate them to the anatomy, correlate them to the physiology, pathology, anything. Link it all up. It makes sense. It's so satisfying. And you're going to feel so much better whenever you answer your future pharmacology question. Cross-link information, connect everything. Neuro is the most satisfying block for this reason. And revise, 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 revise. Lastly, I attached also my neuro note drive. I have everything here from psychiatry, anatomy, physiology, pharma, pathology, microimmunology, everything but neurology, because صراحة that's stupid. You don't have to study. And yeah, thank you all. Please scan this code. Tell me if you ever have any question. These are my contacts. And I hope you guys benefit from this. Inshallah, best of luck on your exam, final, and enjoy your Eid. Eid Mubarak. Inshallah, you guys all got the fattest Eidiyat. And now I can fall asleep. So yeah, thank you guys so much. And forgive me for being late. And Assalamu alaikum.